consultants, amongst our nurses, we have actually taken this initiative in combination with the state NNF and with the OGSH, who both the societies have kindly accepted to be part of the CME and have in fact asked us to do the CME. We are very glad to actually bring up this concept of a perinatology CME in this important domain. So without much ado and waste of time, I would request the office bearers who have come here on behalf of these two important societies. Dr. Surendranath sir, President of the State NNF, is here with us. And Dr. Surender Rao, who is Secretary of NNF, will be joining us shortly. He is on his way. And from the OGSH, we are joined by Dr. Lakshmi ma'am, Dr. Lakshmi Chirmalla ma'am, who is Secretary of the OGSH. Dr. Shantakumari ma'am, President of OGSH, could not join us because of some prior commitments today. We are extremely happy that both the societies could be a part of it, and may I kindly request Surendranath sir and Dr. Lakshmi ma'am to speak a few words and then kindly join us for the lamp lighting. So.
Good afternoon, all of you. On behalf of National Neonatology Forum, Telangana State Chapter, we invite you all for today's first day of the Breastfeeding Week celebration. Normally, the Breastfeeding Week is celebrated from the August 1st to the 7th of August. To encourage the breastfeeding and to propagate the benefits of the breastfeeding, as Madam has already told that we have a marginal increase in the exclusive breastfeeding for first 6 months. It is around 50%, 50 to 60% is the exclusive breastfeeding during the first 6 months. And the initiation of breastfeeding during the first 1 hour is very less compared to the previous years. It has come down. As you know, the breastfeeding is a very simple thing. We make it complicated most of the times. And initiation of the breastfeeding within 1 hour is so easy in the labor room, but still we are not able to do it. About 60% of the babies, almost more than half of the babies, do not start breastfeeding in the labor room or in the OT. So these things have to be taken into consideration, and we should work on that, how to increase the percentage of the initiation of breastfeeding within 1 hour and exclusive breastfeeding. So coming to the breastfeeding week, every year they give some theme to the breastfeeding week. The theme of this year breastfeeding week is for the working parents who are not able to exclusively breastfeed. So how to increase the breastfeeding rates in the working mothers. So that's why the theme which they have kept is enabling breastfeeding, make a difference for the working parents. This is the theme which they have given for this year, concentrating on the working mothers, providing an environment for encouraging the breastfeeding in the offices or wherever workplaces are there. So in fact, PAHA also gave a slogan, let us make breastfeeding and work. That means breastfeeding and work should go simultaneously so that the child will get the better nutrition during the first 6 months of period, and they can do their work at the offices also comfortably. So there are only 20% of the countries which are implementing benefits or giving time for the breastfeeding in the office hours. Whenever they work in the office, the time allotted to the breastfeeding should be deducted. It should be paid for. It should not be deducted from their office hours. And fortunately, in our state, almost 6 months maternity leave is given so that they can continue the breastfeeding as far as possible. So I think we have to consider these things and work on that, impress the government to continue the breastfeeding up to 6 months. The benefits of the breastfeeding, all of you know. The 2 points which I am going to tell is, it has been shown by various studies, the child who is breastfed will earn more than the person who is bottle fed. There are enough statistics which are showing that the earning capacity of the person who is exclusively breastfed is much more than the bottle fed person. And the IQ points also, what they have found is, exclusively breastfed child will have at least 20 points more than the bottle fed child. So there are so many positive aspects of the breastfeeding. I think we have to educate and inculcate all obstetricians and pediatricians to start the breastfeeding within 1 hour and continue exclusive breastfeeding up to 6 months. So with this, I request Dr. Aparna, to start today's program. Thank you for giving me this opportunity.
Thank you, sir. Many thanks to the Telangana State NNF, which has always been a source of undaunting support and encouragement, and has always been so inclusive when it comes to activities, academic programs such as these, where they make sure that every unit that is across the city is made a part of this initiative. Thank you so much, sir. Now may I request Dr. Lakshmi ma'am to please speak a few words.
Good afternoon, everyone. I bring greetings from OGSH, Obstetric and Gynecological Society of Hyderabad, and it's a wonderful initiative, and I extend my special thanks to the NNF team and also the KIMS Cuddles team for involving us in this activity. And definitely we should be having a partnership between us so that the mothers who are going to breastfeed will be educated even in the antenatal period, so that they won't miss that opportunity to breastfeed in the first hour of the childbirth. So I think it should start right from the antenatal period. That motivation should be given to the mother before in the antenatal period also. So that's where the importance of involving the obstetricians comes. So, and also I thank all the organizers for organizing this wonderful conference, and wish you all the best.
I request the team to get the candle ready. So as we mark the beginning of any of our CMEs with the traditional lamp lighting, may I kindly request Surendranath sir, Dr. Lakshmi Chirmala madam, and we already have some of our speakers, Dr. Geetanjali Garu, Dr. Sindhu. I think Shilpi ma'am, our clinical director of OBG, has just gone down for a twin delivery. She will probably join us in some time. Dr. Deepthi, the infertility specialist and joint secretary of OGSH. I request all of you to please come on board. So we begin with a symposium of 4 talks. As we all know, breastfeeding is a journey that begins not just from the baby's birth, but from antenatal preparation of mothers even before the baby comes. So to do this momentous task, we are going to do this in a stepwise fashion, starting from antenatal, intrapartum or labor room interventions. Then we have postnatal interventions, including the use of newer lactation aids. And we shall be also touching about breastfeeding in high-risk newborns, that is, availability of mother's own milk for babies, preterm babies in the NICU. So, to be the moderators or chairperson for this important session, may I kindly request Sir, Dr. Surendranath Sir, to be one of the chairs. And we also request Dr. Deepthi, who is a Joint Secretary of the OGSH, to kindly chair. Ma'am, would you like to? Yeah. Sir, meeru kuda. And since Dr. Lakshmi ma'am is having to leave, I kindly request Surendranath sir to please kindly felicitate ma'am with a small bouquet on behalf of NNF and Cuddles. Bouquet, please. So for the first talk, we request Dr. Geetanjali. She is co-founder and director of obstetrics gynecology at Brindavan Hospital in Secunderabad. And today she is going to talk about this very important aspect of the antenatal interventions that help in optimizing breastfeeding. Thank you, ma'am, for traveling almost more than an hour for being a part of this symposium. And over to you. One touch on this. Can you zoom and can you just make it share screen? Just scan. Duplicate. Okay. Zoom also duplicate. I will share the screen so that whatever is there on the screen you can share. Request if somebody from our team can just ensure that the presentation is getting shared on our Zoom screen as well as YouTube screen. And you can just press the right. Alright, this is the point. Yeah. Good afternoon, respected dignitaries on the dais and off the dais. Of course, I am very happy to be part of a very dynamic pediatric team. Seeing Dr. Aparna, I just wish I can get her energy. She's very, very dynamic, and I think it's because of that you have a lot of, good number of NICU cases in Cuddles. Yeah. So congratulations to the KIMS Cuddles team. You're doing a really great job. So obstetricians, so prenatal breastfeeding. Impact on how does an obstetrician impact a prenatal breastfeeding? So first thing is the first 1,000 days is very important for the baby. I think that's what the pediatrician says. So what is the first 1,000 days? The first 270 days is from the time of conception till delivery, and then the first 365 days is the first year of birth, and the second year of birth is the second 365 days. So the maximum growth of the baby happens in these 2 years and also during the antenatal period. So the maximum brain growth and the head growth happens precisely in the first year. As a gynecologist, I should not be telling it to the pediatricians, but yes, this is true. And where do we play a role? We play a role during the first 270 days. That's when we see the patients, we see the expectant mothers, and we need to really tell them that the importance of breastfeeding during this time, because that's when it all starts. The nutrition and also the way they care for the baby and the emotional and the physical support, everything is needed for a baby. So everything starts from the 270 days, and we actually lose follow-up to the baby post-delivery. And also the mothers, like after postnatally, 3 days, maybe we see them in the ward, and then 1 week postnatally, and then maybe after a month, we lose follow-up. So the most what we can do about breastfeeding is during the antenatal period. And after delivery, post-delivery, they come to us with very few queries, and only if they have an issue, they come to us. Otherwise, they don't come to us at all. So what are the issues we face post-delivery? They are sore or cracked nipples, and or insufficient breast milk, or they might have excess milk which leads to engorgement, or this can also lead to breast abscess and very, very rarely oral thrush. So I have divided this talk into 3 parts. First is the prenatal breastfeeding awareness, and then once we do the counseling, once we do the classes, the second thing is what are the patient's queries, and the third thing, how does the hospital play a role in exclusive breastfeeding. So first thing is they come to us, and when do we start awareness about breastfeeding? So nutrition, we start at 12 weeks, because nutrition, all of us know that nutrition influences the quantity and quality of milk. It's not only in the womb, but even after delivery, even breast milk needs a good quantity and quality of milk, and that depends on the nutrition in pregnancy. And counseling, who do we counsel? Is it only the mothers, or is it the husband and also the family members? We usually start breastfeeding counseling or the breastfeeding classes at around 30 to 33 weeks in our hospital. So that's the right time. And we also include family members if they are available, because in India, grandparents and mothers also do play a role. I'm sure even you'll agree to it, because they are the ones who really tell the expecting mothers what to eat and what not to eat and how to eat and what to do. Because after delivery, many women just get only bread and milk, so they don't get enough milk, and they also don't allow them to take enough water. So all these fads and myths should be, we should tell the mothers and grandmothers that this is not really right, and they need real good food to get good milk. And certain communities, they also, maybe the first feed, they'll want to give their spiritual fluids or honey or water. So all these myths should be broken, and we should talk to the whole family. So I've actually, when I spoke to a grandmother, she didn't beat me, that's all. But I had a good argument with her, saying that the newborn baby should not get whatever the spiritual fluid which she wanted to give. But she gave me a good lecture about it. And so I had to hear, and but we finally convinced her, saying that breast milk is more important than the spiritual fluid. So then once we start conducting classes at 30 to 34 weeks, what are the things which we tell the mothers? So this is going to be a very practical session. There is no theory in it. So this is what we do in our hospital around 30 to 34 weeks. First, these are the slides which I've got it from the hospital, from our lactation consultant, come the physiotherapist, antenatal educator who does these classes. So all of us cannot, all small hospitals cannot have a physiotherapist or an antenatal classes, and we all depend on many mothers depend on the obstetricians, and I think we should take time, and we will take time to explain about the importance of breastfeeding. The first thing is about the baby advantages. I'm sure all of you know about it. And so I'll skip this slide. And the second thing, what we need to tell them is even the mother has advantages with breastfeeding, like exclusive breastfeeding for a year will reduce the risk of breast cancer and ovarian cancer. Breast cancer because there's less exposure to estrogen, and ovarian cancer because there is no ovulation for the time when they breastfeed. And also breastfeeding for at least 6 months reduce some risk of cardiovascular problems like heart diseases and also hypertension and type 2 diabetes. Oxytocin is otherwise also known as love hormone, so it does stimulate and it does elevate the mood of the mother, so there is reduced risk of depression and other mental issues during postnatal breastfeeding time. And it also acts as a natural method of family planning and also reduces bleeding postpartum. And in case if the baby is not fed, breastfed. If it's a formula feed, I think one formula box is it costs around 300 rupees, or maybe I think till 700 rupees, and it comes only for 3 days for a baby. So around 10 boxes in a month might cost, it won't be pocket friendly to a family. So breastfeeding is much better. And formula feeds, they do it with the bottle, and it might have dentition issues. And though they say that formula feeds have a lot of antibodies, they can have more hospital admissions compared to breastfeed. And then we tell them the differences between the breast milk, formula milk, and cow's milk. Breast milk, as we saw, it's designed by human body, and the composition changes to meet the demands of the baby, and it produces antibodies, and it's easy to digest and health benefits. It also has health benefits for mom. Formula milk, it's created by lab, and the composition cannot be changed, and the substances added, like the antibodies, yes, they do have some antibodies, but it's not easily absorbed, and it has more concentration of vitamins and minerals than the breast milk, and it is difficult to digest. It is expensive, and formula feeds are usually given in bottles, and the bottles need to be sterile, or else they might have some infection. And cow's milk, it's out of the question, but people who don't feed, who don't have breast milk and who don't want to feed formula because of financial issues, they land up feeding with cow's milk, but that is even more dangerous. And I think we need to emphasize that it can cause many problems like iron deficiency, anemia, and also the cow's milk protein irritates the stomach and also the intestine, causing loss of blood in stools. And it does not contain healthy type of fat. So once we finish telling them the importance of breast milk, the advantages to the baby, mother, and the family, then we tell them about the golden hour, the first hour after birth. So generally after the delivery, we put the baby on the chest of the mother between both the breasts, and many babies, around 70 to 80% of the babies lift their head and search for the breast and latch. And few babies, when they don't latch, we guide them, we lift them with their neck, and then we guide them to the breast and they latch. So latching on their own, when babies latch on their own, the babies get breastfeed better and longer. And this also helps us to have uninterrupted skin-to-skin contact with the newborn, helping and promoting strong bonding with the mother. The other benefits are it helps regulates baby's temperature, controls the respiration, and lowers the risk of blood sugar. And this is when even the let down reflex starts, and we start getting more milk if we do the golden hour feeding. And then we tell them about the good latch and the poor latch, and all the breastfeeding positions. The laid back and side lying position should be good for the cesarean mothers, because they might not be able to get up immediately after the delivery. It might take some time because of pain. So this laid back and side lying position should be really good. And at the 8th month, when they come to us, we do this test to see what kind of nipple they have, whether it's a common nipple or a flat nipple or an inverted nipple. So how do we perform it? Hold your hand in a C shape and place thumb and forefinger about 1 inch behind the nipple around the areola. Gently push the thumb and finger backwards towards the chest. So in case if the nipple moves forward, it is a common nipple. If the nipple remains unchanged, it is a flat nipple. And if it's an inverted nipple, it will retract into the breast. So this is how we see whether it is a common nipple or a flat nipple and an inverted nipple. So that even if they have a flat nipple or an inverted nipple, please encourage them to feed, and please motivate them to feed, because nipple is not the only thing for feeding. The whole of breast with the areola is needed for feeding, because the latching happens from the areola and not the nipple. So in case if they have a flat nipple, these are the positions which they can hold, how to hold their nipples and the breast, and they can start feeding. So next question, what we face in a postnatal ward is, I have fed the baby is still crying, the baby doesn't have enough milk, it didn't get enough milk, so I have to do formula feeds. So we have to explain that the breastfeeds, the newborn needs around 15 minutes, I hope I'm right, all the pediatricians here. So the newborn needs around 15 minutes per breast every 2 to 3 hours, around 10 to 12 feeds for the first month, and after a month it will need around 30 minutes per breast every 3 to 4 hours, and after 6 months around 40 minutes per breast for 3 to 5 times per day, because when we start on complementary feeding, I think we can also reduce the breast milk feeding. So this is twins, so of course there are problems with twins. These are special circumstances, but this is my friend and she's an obstetrician, and this is the post which she has done Facebook just last month, that she has breastfed both her babies exclusively for 4 months, like tandem feeding. She's done it simultaneously, both breasts she has done it simultaneously for 4 months. So breast milk is all in the mind. If you really want to give your baby, definitely you'll get enough milk. So that is what we really need to tell the parents. And yes, once we are done with the class, as an obstetrician, the only thing the patient wants to know is whether they will have a normal delivery, and that's what they ask. They really don't know about breastfeeding. Once we educate them and create awareness about breastfeeding, they go home, they search, and then they have their relatives and they have their friends, and they all put their inputs and everything, and then they come back with queries. Till then, they never have an awareness about breastfeeding, so that it is really undervalued. So we really need to start about breastfeeding, because it equally has benefits just like a normal delivery. So definitely we'll have to start creating awareness about breastfeeds. So first thing what they come and ask is, how do I know that my baby is getting enough milk? So if the baby is content for 1 to 2 hours after feed, and if it passes clear urine and passes bright yellow stools, I think it's okay if you don't pass even for 48 hours, and regains birth weight after 2 weeks and maintains a good weight gain throughout breastfeeding period. So what if I get too much milk? I think they should come to KIMS Kondapur and donate their milk in the milk bank, isn't it? I mean, I think it's a post-prandial session. Am I? Okay, and this is the theme for this year. Enable breastfeeding and help all the working mothers. Working parents is what is the breastfeeding theme for this year. So want to get back to work, but after 3 months, so what do I do? So please educate them about expressing their milk and keeping it in the room temperature for 6 to 8 hours, or in a refrigerator for 5 days, or in a freezer compartment for 2 weeks. And if it's a different refrigerator and a freezer compartment, maybe 3 to 6 months, they can always store their milk. So once this, in case if they want to store their milk, please do it immediately within an hour. And after storage, if they want to thaw and warm the milk, they should do it in a lukewarm container. And once milk is thawed, it should be used within 24 hours. And if it is warmed, if it's warmed and not used, it has to be discarded. Yeah. The next big question is, what should I eat to get good amount of milk? I think we have a very big debate on galactogog, so I didn't really concentrate on this part. So nutrition, as I said, nutrition influences the quantity and the quality of milk, and it's just a well-balanced diet. Galactogogs, yes, it will definitely help, but balanced diet, less stress, good sleep, this will really help in breast milk secretion and production. So, and also to drink 8 glasses of water a day, because dehydration can also reduce the quantity of milk. Avoid or limit coffee and avoid alcohol and smoking. So other queries what they have is, will there be pain? Pain, I think, is because of the latching technique, and this can be always solved. And the second thing is the shape and appearance is a new question which we are facing since last 6 months or 1 year. Shape and appearance, one of my friend's friend, though she had 2 normal deliveries, she didn't feed her babies because she was scared that her appearance of the breast will change. So there are people who think that it will change, but with good support during lactation and exercise after lactation, definitely I don't think there will be a change in a breast appearance. Maybe 80 to 90% they can always be the same. And if milk production reduces after some time, what do I do? So this is a very common question what we face. We don't have good enough milk production. What do we do? So this breast milk, as I say, it's always in the mind. If you really want to feed your baby, you'll get enough milk. My professor during MBBS days, Dr. Nalini, I think this year she's got Padma Shri for hemophilia. She was my professor in MBBS, and she always promotes and encourages people who ever stopped feeding. If they have stopped feeding, if they come for vaccine at 1 year, she'll tell them, feed the baby, start feeding. We asked her, how do you get milk? They said, it's all in the mind. If she thinks, if she wants, she can get milk again, breast milk, and she can feed the baby till 2 years. So that is what we learned from her. And yes, we have seen very rarely in a couple of patients that who have started feeding, who really wanted to feed their baby for 2 years. We have seen breast milk production even after they have stopped their feeds. And pediatricians here, I think there's only 2 absolute contraindications like galactosemia and mother on antidepressants. Rest all like HIV, HPSAG positive and TB are relative, because in our setup in India, low socioeconomic status, if we tell them that HIV don't feed, they might not feed, they might give cow's milk, or they might not be affordable to get formula feeds, and baby might go into malnutrition. So always breast milk is much better than not feeding the baby at all. So what can a hospital do? So these are the 10 steps to successful breastfeeding, the breast-friendly hospital initiative, and all of you know about it. First thing is breastfeeding policy. There should be a written policy, breastfeeding policy, and then we should train all these staff in the hospital. Certain things what we can do is when patients sit in the OPD, maybe we can play some collaterals, or we can play some role plays, or we can give them small booklets and create awareness about breastfeeding, and we can always hold classes. Certain things which we can do, and train all our staff, not only the lactation consultants, train all our staff nurses and whoever handles the babies, how to breastfeed and how to hold, the holding technique, and all that we can do. So that these are very, very small things which will take us a long way and will help in breastfeeding, because India, Southeast, whatever I read with the WHO reports, India ranks the 7th in breastfeeding, and it's only 55% of the mothers who are breastfeeding, with the largest population in the world, but still we are only 55% and we rank 7th in breastfeeding. I really don't know why. But I think we should step up and we should start this, because there are many advantages to the mother, to the baby, and also the family. And it's going to help. I think, as Sir said, Sir was telling in his speech that breastfeeding babies earn better than formula-fed babies. I think this should be our statement to every mother, every family, so that I'm sure if it's anything about the financial thing, definitely they will start breastfeeding the baby. They'll take time out for breastfeeding and they will not give excuses. So that's a nice point, sir. So I think we should use this, and we should tell every mother that, yeah, if you breastfeed your baby, he's going to do better in school and he's going to earn better for your family. Yeah, with this, so obstetrician's role is, I think we are the directors, and the true heroes are the pediatricians, because they come to you at the end of the day. So awareness, encouragement, patience, positivity, and mainly reassurance to all the expectant mothers and postnatally. I think that's what we should do to have exclusive breastfeeding, to start with exclusive breastfeeding. Thank you.
Thank you, ma'am. That was an extensive talk, and you have cleared all the antenatal doubts on breastfeeding. Thank you. I'm honored to invite Dr. Vijaya Krishnan, ma'am, who is a medical director and founder of Sanctum Natural Birth Center, who is my all-time one point of contact, and whom I already, she knows about it, only one point of contact for my lactation. Thank you, ma'am. Please give an give an opening for us for an intrapartum breastfeeding in the intrapartum. What is the intrapartum plays a role in the breastfeeding? Thank you.
Thank you, Dr. Sindhu, and thank you, Dr. Aparna, for inviting me over here, and happy breastfeeding week to all of you. Dr. Surendranath. So my topic is a little bit, I thought this would be a little bit of an eye-opener, because what are the impact of interventions on breastfeeding? Because I think as a routine process, we all know that birth has become sort of medicalized, and for good reasons and bad. Sometimes we do need that over-medicalization. Sometimes those things do save lives, but relatively, when we are talking about the natural processes of birth and therefore breastfeeding, if we don't look at what we are doing in the intrapartum period and how that affects the breastfeeding, I think we would be sort of skirting around the issue. So that's where this topic comes in. So what does a newborn baby want? It wants love, it wants warmth, and it wants food. And all three are easily available at a mother's breast. But what does a newborn baby need to thrive? And basically, I'm just going to go back one slide. So these are what it needs to survive. And what does it need to thrive? The baby needs a feeling of safety. Baby needs to hear the rhythms of a mother's heartbeats, familiar voices, cooing, familiar smells. This is the baby that has been inside the womb, comes outside. We all know the power of the amniotic fluid. That's what the baby smells when it puts the fist to, the nose, and the mother's breast does produce the similar kind of smelling hormones. So that's eventually what helps with the baby to even do a breast crawl and latch. So familiar smells. warmth, touch and caressing, love. And we talk about what we can do, but love is the entire source of breast milk production because that's oxytocin. And it was needed to conceive the baby, it was needed to get the baby out, it was needed to get the placenta out, and love is what gets the oxytocin flowing as a precursor for the prolactin eventually to come in and for breastfeeding to happen well. Bonding and of course breastfeeding. So then the question becomes for all of us here, is survival enough? What about failure to thrive? So when we look at in a gynec or a pediatric perspective, failure to thrive just becomes numbers. Is the baby lost weight? Has the baby had a 10% weight loss or a 5% weight loss? But the failure to thrive can also be the imprint that this baby has had at birth and beyond. What about a mother that is too tired to receive her baby? What about a mother who is drugged from medications at labor and birth? Now, it's not that we are doing this intentionally, but unintentionally. We are often giving the mother sedation, saying, Pavam, she is too tired, right? And then what about that mother who cannot really bond with her child because she is too tired and drug? A baby who is not alert and awake. One of the things that I constantly teach my students is what happens to mom happens to baby. So if mom is not alert, aware and awake, the baby is not alert, aware and awake. Of course, birth was meant to work. Even in the forest, if a mother gave birth, the baby would, eventually want to survive. But these are problems that we face. A baby who is separated from a mother and now has to defend herself to survive the stresses of the outside womb. A mother who is told she has no milk, because oftentimes what does happen in the hospitals is you press the breast, you don't see a drop, and then you're told, well, there's no colostrum. And so that's a stressed mom and a stressed baby. Can breastfeeding initiation happen with such stressors in the mom and baby? Good things to think about. So the result is difficulty initiating breastfeeding, difficulty continuing breastfeeding, and I always say this, despite these, warrior mothers absolutely want to breastfeed their babies, most of them. So what are the interventions that we are seeing in childbirth? Some of them have become so common that we even don't recognize them as interventions. The IV cannula that is almost placed immediately as the mom walks into labor. Fluids that are routinely given to the mom. Many times withholding of food and water. I think we are becoming better at this, but still withholding food and water, because what if you need a cesarean section? We know that there is absolutely no evidence to withhold food and water, but still it is withheld. Or just have ice popsicles, or just, have lightest kind of food. Medicines to speed up labor. These are becoming so routine that we don't recognize them. If it is not going at 1 centimeter per hour or 2 centimeters per hour or whatever it is, augmentation is happening so routinely. Inductions are happening routinely. I would say 50 to 60% because we hear the stories of moms, right? That the inductions are happening routinely, but so are augmentations. Medicines to give relief from pain that we have artificially increased. We are not understanding often that the Pitocin that we have given has increased her pain, and therefore now you have to eventually get medications to relieve her pain. And then episiotomy for first-time mothers is fairly routine. So what happens with that? Where she can't get up, she can't sit, and often is sitting on one hip for 3-4 weeks. So we have to look at that and see how is that impacting it. Separation of mother and baby, fairly routine. Yes, government wants the pediatricians at the birth. I completely agree with that. But what about that immediate separation? Baby is born, given away, put on the warmer, dried, suctioned, mouth, nose, weighed, sometimes checked with blood glucose. All these become completely routine. We don't even stop to think about it. For the baby, it's hearing all sorts of weird things, not the mother's heartbeat, right? And baby formula in first few hours, not perhaps in places like this, and things are getting better, but in many places it becomes fairly routine if the mother is not, sort of the mom and baby are separated. So where is the birth physiology in all of this? I talked about this, oxytocin is love. So as the oxytocin increases, when the labor starts on its own, this is the key. How many people are told that you crossed your due date, get the labor started? Or how many parents, grandparents come and tell us, my daughter has crossed her due date, please induce her. You know, it's like you reflect fear to the society, society reflects fear back to you. So you're now in this cycle where you don't have any way to get out of it. So you have completely negated a process that should have been started. So you don't have that love hormone. You're going in fearful. A bunch of procedures are done. You're given your gown to wear. You're probably put in a room and said, lie down, it's okay. And we have a TV. You can watch TV until you're, I'm trying to be flippant about it. And nobody says that, but essentially that's what you're doing, right? You're putting in there and saying, let labor start. But we are negating the oxytocin, right? Endorphins. So when the oxytocin rises, so does endorphins. And bear with me for a minute, endorphins are nature's feel-good hormones. We have had it in us from time immemorial that when the oxytocin rises, so does endorphins rise. So pain and pleasure become two sides of the same coin. For the mom who is experiencing the pain, she's not suffering. You can have many kinds of suffering in labor, but she's having pain, but she's also producing endorphins to take care of the pain. That causes a feeling of high. It's a peak flow feeling. If I have trained for running a marathon and I run it, at the end of the marathon, I feel fantastic. I might have struggled to start. I might have stuttered. I might have said, oh no, this feels terribly hard. But then I finish it, and that's the peak flow feeling that she has. Now we are taking that away from her. Catecholamines come in towards the end, when an alert mom and an alert baby both are there to receive into each other's arms. And these catecholamines actually have a very important function in a normal natural birth, which is primarily prepping the baby for stresses outside. We don't have that. We have fear catecholamines, not the natural catecholamines coming in, right? And that causes longer labor. Oxytocin prolactin complex, all of you know, I won't go into it, that left the letdown and the milk production. Oxytocin also leads to relaxation. We are forgetting that once the stressors are not there, the mom and baby can actually relax. When a breastfeeding mom, for any of you who have, had the opportunity to take care of your babies, feed the babies, you feel sleepy when you're breastfeeding the baby, if you're not stressed. That's a different story. Many of us are so stressed that we don't know, we're looking at this baby like as if something horrible is going to happen. But that relaxation and protective mothering, we call oxytocin the love hormone, and we call prolactin the mothering hormone. That gives intense feelings of mothering so she can take care of her baby. And what about that? So love, bonding, thriving, all of that is happening. So respecting physiology, normal natural birth sets the stage for optimal start to breastfeeding, while a complicated intervention intensive labor sets the stage for problems. And I hope we can recognize this. So little intervention here and there, IV fluids, and for those of you pediatricians, you know this, when the mom is overloaded with IV fluids, her body swells, including her breast. That makes it difficult for baby to latch and feed. For the baby, it gives an artificial weight gain, and then it drops, and then we are worried that we have lost a lot of weight. It can look like excessive weight loss and can trigger formula supplementation. Induction augmentation, I just briefly touched upon it, but this is the synthetic oxytocin does not do the work. It does not cross the blood-brain barrier. While the normal oxytocin in the body crosses the blood-brain barrier, gives those endorphins for the mom to get relief of pain, the synthetic oxytocin does not cross the blood-brain barrier, so she has a double whammy. She's feeling this intense pain, but no pain relief from the body systems, right? So that there she takes other pain relief medications, epidurals come into place, which leads to other cascades of interventions. For the baby, the induction, we always talk about the due date, but we really don't know what the due date is. We have said that this is by a rule, we have calculated 280 days, but when we intervene early, and there is all these terminologies, we have late term, which is 37 to 39 weeks, 39 to 40 weeks, and 6 days is term. So we have these terminologies, but inducing a baby which is really not ready to be born, we have the risk of a near-term or late-term baby who then can have breastfeeding difficulties. And abnormal low natural oxytocin, we have to question what is the effect on love and bonding and breastfeeding. Epidural, that can cause its own cascade of interventions. Rates of forceps, vacuum delivery increase, we know that. Also from the baby's side, when the forceps and vacuum deliveries increase, there can be bruising, there can be pain in the baby. Oftentimes babies will want to feed only on one side or on another. And this can happen even with a normal natural birth without interventions. But when the other interventions are happening, we have to wonder, why is that baby sort of pushing away? Why is the baby tilted to one side? Why are we not able to breast? Why is the mom and baby not being able to feed with ease? Some of these difficulties definitely arise. The longer the epidural, there is a chance of fever in the mom, chances of fever in the baby, more investigations, and separation of mother and baby. And last but not the least, I think there has been enough questions put up about this, though there is no long-term studies that are done. But we have to think when the pelvic floor relaxes, when there is no coordinated effort on the mother to be able to push a baby out, there is a uncoordinated suck, swallow, breathe effort in the baby as well. So oftentimes the babies who are born after an epidural have an increase in the initiation, suck, swallow apparatus, just being able to really have coordinated efforts in breastfeeding. That can happen. So I'm just a little few visuals here. Oftentimes labor and birth looks like this. And then that's the current hospital scenario. Separation from mother, bright lights, loud sounds, testing, weighing, cleaning, bathing, perhaps suction, mouth, nose, whatever, sometimes glucose checks, warmers and monitors that beep, and then handed over to the relatives. Babies cry when they are put in the warmer. They cry, cry, and then they shut down. And by the time they come to the mom, then we say the baby is not waking up to feed. There starts the interventions. Baby is not feeding, not feeding, not feeding. Now the day has gone, now there is weight loss. So that shut down baby is also saying to the world that I am not able to process these stresses. And we have to look at the long-term impact of this. And finally, last but not the least, the mother-baby microbiome. Over the last several years, we have begun to understand what is the importance of the microbiome. Microbiome is what we all are carrying from our ancestors. And because the vagina is so replete with good microbes at birth, we ingest that, and that's the first part of our gut microbiome, which then flourishes. We have 3 trillion bacteria, but when we separate the mom and baby, we suction, we betadinize the vaginal area as if we are getting it ready for a surgery. Baby swallows that and comes out, and then comes out and is separated and put in a warmer in sterile conditions. Microbiome is lost, and then there are all these autoimmune disorders, difficulty with gut processing, intolerances, so many things we are understanding now for how important the microbiome is. And what is just the little formula? Mixed WHO mixed feeding stats. Breastfed babies are 14 times likely to are less likely to die in the first 6 months than formula-fed babies. That is 800,000 children per year. Prevents half of diarrheal diseases and 1/3 of respiratory diseases in the first year. And these are comments we hear all the time. I wasn't shown my baby after the cesarean. My baby was given away and given to me only after 2 hours. I didn't get to breastfeed my baby during the golden hour. My baby was given formula because I was too sedated from the cesarean. We hear this so often. So I thought I would also talk a little bit about, even though cesarean is an intervention, what are the practices that can impact breastfeeding positively? That's a mom who has received the baby right on her abdomen. We have enough ability to have a sterile field and still have the mom be able to touch her baby. So that brings that sense of oxytocin. That's what she has worked for 9 months. And I am wondering if it will play. I'm hoping it will sometimes. And can we get technical support here? Because I did want to play this. Was this downloaded? Or is it from Google site? Because there's a video, there are a couple of videos which I would really like to play. This is a video. Can you just be here for a minute? So again, this is possible that even in a cesarean section, we can wait for the placenta to be born. Dr. Sindhu is a part of my team. I think it's you over there, isn't it? Yeah, so we oftentimes wait for the placenta to come unless there is an emergency, and we make it like a vaginal birth, blood loss is minimized, and the dad still gets to cut the baby. Again, it's the circle of love and connection that is there. Okay, again, this is the video. One second. So that's a mom on the cesarean table. Baby is onto the breast, breastfeeding happily. So while the mom is getting sutured up, she gets her share of oxytocin, baby gets the share of oxytocin, and breastfeeding relatively happens easily. Now, not everything is pink flowers and purple rainbows. Sometimes things go wrong after that also. But that's where lactation consultants are there, and Rama is there as a part of my team, and she works her magic. But this is the start that we would want for a baby, isn't it? Even if there were interventions. So these. Couple more at the end. We're almost coming to an end. Sorry for the technical glitches, always happens. What are the stats? These are the stats. The speaker before me was talking about this. Stats for initiation is 50% within the first hour, and then at 6 months, 55%. We have a 100% breastfeeding rate at discharge and 98% at 6 weeks, and we are extremely proud of that because we work really, really hard round the clock with supporting the moms. Being able to really work with them, and yes, sometimes we do hit glitches. Sometimes we may have to introduce a little bit of formula simply because just to get them over that hump, and then we usually have them, at with the really good, and the mothers really want it. That's at the end of the day, the moms will have to want it. Significant portion of them are exclusively breastfeeding at 6 months, significant portions are breastfeeding at year, 2 years. Many of them come back for their second babies and are still breastfeeding, and many of them tandem feed and feed the baby while the second baby, she's pregnant with her second baby, and then there are people who breastfeed their toddler and their newborn child as well. So we have all of those. So I think it's really good when we are able to support them at every stage. And so what are some of the things we routinely do? Lamaze classes. There is a good portion of our Lamaze classes, which is our antenatal, childbirth education classes, which devotes to breastfeeding. We also have antenatal and postnatal specific breastfeeding education classes. We have a pediatrician who is part of our integral efforts because without her we could not do it. And I remember clearly when Sindhu joined us about 3 years back that it was, I don't know what they are doing. And then she's like, no, I can come in now. I can see the baby at the bedside, right? So it's really important to have a good team. And thank you, Sindhu, for everything that you do. Skin to skin in the first hours or hours, and individualized lactation support and counseling. Video. So I just wanted to give a glimpse of what can be an undisturbed birth. And if the lights can be dimmed a little bit, it would be really, really sort of soaked in the moment. not downloading. Do you want me to play it from my, but then again, I can do it from my computer. But in Google Slides, it should play, no? No? The one before that. You want me to look at my computer? I'm not sure whether it will work or not. So, do you want me to bring my computer on? And if it's not playing, it's okay, I guess. I don't want to hold people up. If you can try it with this, if it's not playing, then leave it. One second. I have to go back onto my email. That's where the slides have been sent to. I don't know whether this is enough. Okay. Otherwise, we'll move it forward. It's okay. Because if it's giving trouble, then I don't want to waste time. It's okay. It's okay. I'm just going to skip it. That's all. It doesn't make sense to make people wait. Yeah, just go through that. Take this. That's all right. Yeah, next. Yeah, next. Okay, this is not playing. Okay, that's fine. We just go to 24. Yeah, that's it. That's it. No, this one is also a video, so we go back and go to the next one. Yeah, I'm just going to skip the videos. So one of my mentors talks about the newborn and the 3-foot halo. So basically what it means is when the baby is good, mom is good, leave them alone. Don't be in their circle. Don't talk to them. Don't be in their face. Just give them some time, because that's the time when the mom and baby are getting to know each other. And this is a perfect example. She is a little bit tired from the birth. She's closed her eyes, but the baby is looking for the breast. It's just one of those times when you want not to talk too much, not to ask too many questions. And of course, there are things that you need to do in terms of making sure that the mom and baby are safe, but it can be done in a very safe manner. One of the births that we had fairly recently, the mom had given birth, and then the dad actually reminded her, do you want to sing the baby song? And then the mom starts to sing, and she is singing and singing, and eventually she writes me a letter saying that me and my husband, we were so thankful that you gave us that time, because you had 5 more people were there in the room, but we felt like we were alone. And that tells us the story of how we want to, let the mom and baby be. And the breast crawl, for those of you many of you would have seen it, but this is all the stages, and it takes some time for the breast crawl to happen. It's not a prescription that every baby has to breast crawl. Some will do it sooner, some will do it later, sometimes it takes upwards of an hour, but when it happens, it's absolutely beautiful to watch. And that's again a very, very confident mom, a calm environment, and the baby trying to reach for the breast. And then finally, I think this is what I want to leave this image with you with. There is a mom and a dad in love with each other and a baby breastfeeding. Aren't we all working towards this? And if each one of us, in however we do, our work every day, if we can enable this moment, I think we would have set up at least to some extent a beautiful and optimal start to breastfeeding. And that's where you can find us. And thank you for being patient and for all that you do for moms and babies. Thank you so much.
Thank you, ma'am. That was an intensive talk, and I know you all just talked whatever we are following at Sanctum. Thank you, ma'am. Next, I would like to invite Dr. Vinoda Unnam, a talk on lactation aids, how useful lactation aids in successful breastfeeding. Thank you.
Hello everyone, good afternoon. Myself, Dr. Vinoda. Thank you for the introduction and thank you, Dr. Aparna, for the opportunity to speak about this topic. How useful are lactation aids in the breastfeeding journey of a term baby? So myself, I'm also a clinical physiotherapist apart from a lactation consultant. And I'm a breastfeeding promoting network member, and I've been doing as an external assessor for helping the hospitals become breastfeeding friendly, BFHI friendly. And I'm also a labor support professional and hypnobirthing practitioner, and I also teach pre and postnatal exercises. So I would like to start with a note that we all believe in this, that the more we know about human breast milk, the more we discover about its value in human nutrition and development. And we all I need it. Breastfeeding is the best feeding. And as Dr. Vijaya has mentioned, birth has become medicalized. And we have given something to the society, and it is still there in the society, and we need to work on bringing this back. So when considering a lot of breastfeeding going on, when we are talking about the breastfeeding aids, there's a pediatric review conducted by which is present in the International Journal of Pediatric Research. This is conducted by Namrata. Dr. Namrata is a pediatrician assistant professor. She worked on the various determinants of bottle feeding among 0 to 24 months of children, and the result is not a surprise. Bottle feeding is seen in all socio-economic classes, and can you guess in which economic class the bottle feeding rates are high? Low socio-economic or high? Yeah, higher upper economic class, there is more rate of bottle feeding. And I have highlighted the percentage of the people involved here, who, for what reason they have been giving bottle feeding. One is the rate of cesareans, LSCS, 30.3%. Mothers who underwent cesareans were bottle feeding. 69.7% mothers had a belief that there is not enough breast milk, and 99.5% mothers don't have proper knowledge on breastfeeding in the antenatal period. 31.8% said that the nearby circle, family members, to start bottle feeding. 28.79% had an unsupportive father. So there is a strong need for lactation counseling in the antenatal period so that the mom can successfully breastfeed. So why are we against the bottle? Because bottle feeding creates a flow preference and babies refuse to breastfeed later. And bottle feeding has more chance of choking, coughing and aspiration. There are more chances of infections and overfeeding. Apart from all this, bottle feeding does not aid in the craniofacial development in the same way as breastfeeding, and we will get to see what happens in bottle feeding. Bottle feeding can separate the epiglottis and the soft palate connection and elevate the soft palate. It drives the tongue back and it alters the action of the tongue. Normal action of the tongue is the peristaltic movement of the tongue is affected. Instead of that, the pistoning effect is seen. So this is the vacuum created, and it can create an inward collapse of the oral cavity, the throat and the airway. The mouth has to adjust to any object in the mouth other than the breast. Anything else is a foreign object, and these unnatural forces that can develop will impact the position of the teeth and the shape of the palate. The muscle forces always win out over the bone, and the teeth will be moved, and the upward forces on the palate and the vacuum can alter the entire of the oral development, and we can see crossbite or malocclusion. And when you look at the infant who is exclusively breastfed, the mouth is so different from the infant who has sucked on a foreign object exclusively. So Dr. Neil, who is in Obgyn, he did a 4-year of ultrasonic research on this suction, and it stated that 100% of babies who had piston tongue action had used the bottle teat, and they find challenging to breastfeed. And those who did not use the bottle teat, none had abnormal piston action, and they all had rocker or the wave or the peristaltic action, and it is easier for these babies to train onto the breast. He prefers to use the term suck confusion rather than the nipple confusion, and his research showed that there is a mild suction during breastfeeding to hold the nipple, but a stronger suction is needed to suck milk out of the bottle, and we can conclude that modern is not always better. And why do we still see this bottle feeding surviving? Because it is giving a good feedback to the mother. She can see the whole bottle is getting emptied, and mom is getting a good feedback that baby is fed well, unlike breastfeeding where she is not able to see how much has the baby taken. So what if breastfeeding is not an option, and what are the alternatives to bottle feeding? Other options can be syringe feeding. These were the options. So syringe feeding, spoon feeding, katori feeding, cup feeding, palada feeding. So cup feeding, what are the benefits and what are the risks? So cup feeding prevents this malalignment that we talked. Misalignment of the teeth and the abnormal development of the jaws is not present, and it is safer, and it helps with the dental caries. It reduces the dental caries, and it prevents overfeeding in babies. It eliminates the need for the special cup training after the baby is moved, after the breastfeeding, when the baby is introduced to solids, and it is very affordable. So what are the disadvantages? The risk of choking, we can see that baby is spilling the milk there, spitting up if feeding is not done properly, and there is a wastage of breast milk, especially if they are feeding expressed milk, there is a lot of wastage, and the feeds may take very long, and the long-term use might develop a preference for it over sucking milk from the breast. So which babies need cup feeding? Premature babies, weak, sick babies that do not yet possess strength to breastfeed, they can be introduced to cup feed. Babies that have trouble with sucking from breast, latching problems, tongue tie, inverted nipples, till the problems are taken care of. So babies who need supplementing because of low birth weight or weight loss, or if the mother has sore nipples till she learns to latch well, or if the mom is sick till she becomes better. But this cup feeding has been improvised. So to address all these problems that the cup feeding was causing, a team of investigators from Seattle Children's Hospital, in collaboration with the University of Washington and PATH, they have designed the Nifty feeding cup. So what is this Nifty feeding cup? It is neonatal intuitive feeding technology cup. So baby is very much part of the sucking from the cup instead of the mother pouring over into the mouth. So baby has better control. And a randomized crossover trial comparing the Nifty cup to a medicine cup has been conducted in Ghana, and we can see that the mothers preferred the cup. 75.3% mothers have preferred this Nifty cup over the regular medicine cup, and only 24 said that the regular medicine cup was fine with them. Mothers were able to feed with a lot of confidence, and they said that they were able to easily express milk into the Nifty cup, and again instead of transferring to another bowl, they could express in the same thing and also feed the baby with the same. So what are the reasons? Reusable, Nifty cup is boilable and autoclavable. We can monitor feeding with millimeter feeding measurements on the side of the cup. The soft silicone material is gentle against the mouth of the infant, and the reservoir of the Nifty cup, it helps the infant to lap milk from the cup and have a better control on the pace of feeding, and mother can express directly into the Nifty cup. So what about the acceptance by mothers and healthcare providers? A comparative study of two infant feeding tools, the Nifty cup and the Palada, our traditional Palada. This study was conducted at Sri Ramachandra Medical Center Research Institute in Chennai, and 43 caregivers, 28 healthcare providers said Nifty cup is more promising. So what if these babies are helped to transition onto the breast? What do these babies do at the breast? They are usually fussy, they are sleepy, they push away, they refuse because the flow is slow. So can we supplement milk at the breast itself? Yes. So supplementary lactation kit or a lactation aid is a device that allows the baby to be supplemented with expressed milk or formula at the breast itself. It has a container and a feeding bottle and a thin medical tube which is a 5 friends or smaller than that. And the usage is insert this tubing. You can use it in two ways. You can either insert this tubing after the baby has latched onto the breast, or you can hold the tube alongside the nipple and bring on the baby for latching in this way. So you can either do it after the baby latched, or you can insert it along with the nipple. So what are the benefits of this supplementary nursing system? The baby is not nipple confused or suck confused, unlike the cup or bottle feeding. And the baby suck is also stimulating the breast as well. So baby gets more practice to do breastfeeding well, and mother is able to enjoy the full experience of breastfeeding, and baby associates feeling full at the breast, and this reinforces his desire to breastfeed. And this can speed up or slow down the flow as per the baby's need. So the key points here to remember are, we can control the rate of flow of the milk when the height of the container is higher than the level of the baby's head, the flow is usually higher, and when it is brought down below the head level, the flow is lower. And also the diameter of the tubing, if the wider diameter is used, the flow is faster, and otherwise it is slow. So you can modify it according to the benefit of the baby. So what are the disadvantages? It can be difficult to use, it is difficult to clean the little tubes, and it may not work with all babies, and it only works with good positioning and good latching. If the latch is not good, if the baby is having supposedly a tongue tie or mother is not knowing how to latch properly, baby will tend to suck only on the tube. So tube can cause gagging sometimes if it reaches too far into the baby's mouth, and the formula can clog sometimes, and the milk flow may be obstructed, and again the baby may become fussy. So when we are transitioning the babies onto the breastfeeding, we can simply follow a small table of this sort to help the mother and us to understand a little better how far the bottle feeding durations have come down, the number of bottle feedings have come down, how many times finger feeding is introduced, and feeding at the breast, how many times is done, and how much breast milk supplement is done or the formula supplement is done, how much skin to skin contact is being given, and the pumping durations, the urine stool can be checked, and these can help the mother to do better. So actually one mom is supposed to come here and tell us about the benefits of using the SNS that we had used for her. She herself is a doctor, she is a gynec, and her baby is not well, and that's the reason she is not here now. So she had approached me on day 7 or day 11 actually, and from day 1 she's been trying to breastfeed. She gave colostrum 2-3 times of breastfeeding happened, and day 2 she didn't breastfeed. She tried for 3-4 times and baby did not latch. But now she tells me that I don't know, I had given the breastfeeding, but I'm not sure after observing the correct latch now, I don't think I have fed my baby properly. And day 3 to 5, the baby didn't breastfeed at all, so mom was expressing milk with spoon and palada. And day 5, she visited a lactation consultant who advised nipple shields and breastfed with nipple shields, and she expressed milk and gave with palada again. So day 7 to 11, she tried using the nipple shields, but baby was never satisfied and used to latch for hours together, and all these days she expressed milk and little extra support with the palada was taken. Day 11 to 16, she didn't use the nipple shields, she only did expressed milk with palada, and day 17, she expressed milk, and one feed at night was formula milk and given with a bottle. Then she met me and we stopped the bottle feed and she breastfed at the right breast. She is having a challenge on the left breast. She was not able to feed, but our bottle has gone and our palada is gone. Here we have tried to give the supplementary nursing system. Baby had positively associated and mother has learned to do a proper latch, and night 2 feeds were given expressed milk with the palada. So till the mom and dad were comfortable, both of them were doctors and they were pretty comfortable to do it. So again day 24, she met me again. Once the feeding tube was stopped, now she is not using any bottle, and the challenge on her left breast is also fine now, and she is doing breastfeeding on both the sides. So I felt it was quite easier to help these mothers with the supplementary nursing care. So thank you so much.
So for the next session, which is going to be on interventions to improve mother's own milk feeding in the NICU, which is something of course very close to our heart. I have Dr. Sindhu with us. Dr. Sindhu is a consultant neonatologist and pediatrician. She has joined our branch at Gachibowli recently, a very enthusiastic speaker and a very young and dynamic neonatologist. Over to you, Dr. Sindhu.
Thank you, ma'am. Getting such kind of introduction from my teacher itself is like, I don't want to give this talk anymore. Anyways, till now we were talking about breastfeeding and a term baby who are close to each other. So studying so much of establishment of a breastfeeding for a term baby, and we are having so many breastfeeding week, run, walk and all these things. Now I'm going to talk on breastfeeding on a preterm babies, who are separated from each other, and which is very challenging from all of us from the obstetric point of view, from the neonatal point of view. Let me talk a brief about, so as per the recent recommendation of the American Academy of Pediatrics, all preterm infants should receive human milk, and all babies, low birth weight babies less than 1500 grams, and all the preterms should receive human milk which has been fortified with proteins, minerals, vitamins, and to ensure an optimal nutrients. If in case of breast milk is not available or contraindicated, pasteurized donor milk is appropriately fortified. Why human milk? Apart from the term part, when it comes to the preterm babies or low birth weight babies, the breast milk is, human milk is more of an immunonutritional advantages for a preterm babies. Nutritional. So if you see a chart table which shows the usual recommendation of SPCN recommendation for a preterm baby, and then these are the express breast milk if you give a baby with an 180 ml per kg per day, and these are the nutrients. Sorry. And express breast milk, if a baby with an express breast milk with an 180 ml per kg per day, still the babies will have a deficiency in proteins, vitamin A, D, and calcium and phosphorus. And if it fortified with an HMF, that is a human milk fortifier, the enough nutrients will be achieved, only will be deficiency in zinc. When it comes to a formula where we can't be fortified, so it will be, we supply a baby with the exclusively formula fed with an 180 ml per kg per day. The babies will have a deficiency in protein, vitamin A, D, and zinc. After nutrition, here comes an immunological. We all know that human milk contains and secretory immunoglobulin A, lactoferrin, lysozyme, growth factors, which ultimately decrease in necrotizing enterocolitis. I think they are audible with my voice. And glycosaminoglycans, GAGs, which act as a precursor for the pathogenic bacteria to enter into the circulation. They act like an attached to the pathogenic bacteria and prevent entry of the pathogen bacteria into the circulation. Next, bioactive molecules present in human milk are important components of the innate immune system. Bile cell stimulating lipase, which is present in the breast milk, helps in digestion of the fats in preterms, which is tough for the preterm babies to get digested. So the bile salt stimulating lipase, which is present in breast milk, will help in the digestion. The other molecules present in the breast milk, like leptin, which is useful for the postnatal growth, and breastfeeding is one of the most important influence composition for the intestinal microbiota of the neonate. And the last but the most important and recent trending one was human milk oligosaccharides, which now all the formulas also labeling as they have documented, or they have having human milk oligosaccharides. What is the major role of human milk oligosaccharides in a breast milk? Human milk oligosaccharides act like a prebiotic, and they act also like a decoy. It means that they line the mucosal lining of the intestine, and they capture the pathogenic bacteria and prevents entering of the pathogenic bacteria inside the circulation. And the provision for fucose and sialic acid also, which is an important host defense and neurodevelopment. After coming to the breast milk, why only mother's own milk? Why can't it be a donor human milk? Though the next option comes with the donor human milk, but the mother's own milk is the best. So why? Term infants, so most of the donor human milk which we receive from the donors are from the term babies. So mothers who has delivered a term baby, or who has been like 1 month or 2 months after the delivery, they start pumping it out if they have excess, and they start storage. The milk in the donor human milk, protein in the donor human milk is around 0.9 to 1.1 gram per DL, whereas in case of preterm milk of mother's own milk contains around 1.4 gram per DL. And after getting the after taking the donor human milk, the process starts with like pre-pooling, pasteurization, post-pooling, and all these things. After the pasteurization and administration, by the time the baby receives the human milk, donor human milk, there is a loss of 9% of protein and 13% of fat. and the host defense mechanisms present in the mother's own milk get inactivated. That is, like as I have discussed previously, that is secretory IgA, lactoferrin, lysozyme, bile salt stimulating lipase, lipoprotein, all this gets inactivated by Holder's pasteurization, which is a technique which we right now use for the pasteurizing the donor milk. So the nutrients in donor milk are highly variable. Like at what time, at what stage of lactation they are doing, at what time, how they are collecting, what is the technique of collection, all this matters with the nutrients in the donor milk varies with the donors who we give, and how do we pasteurize, pre-pool, how are we mixing it, everything matters for the good amount of nutrients in the donor milk. If we take a chart with the preterm and the term mother's own milk, apart from the donor human milk, if we see giving a baby with a term milk, the preterm baby's mom contains, in the first week it contains around 60 calories and the protein is 2.2 grams. When it comes to a term moms, where the calories are around 60 and the protein is around 1.8, which is less than the requirement. As by the weeks increasing, the calorie content keeps increasing in the preterm moms as compared with that of the term moms. By the end of the around 10 to 12 weeks, the term and the preterm mother's own milk becomes almost equal. Next, the main thing, benefits. The benefits of the mother's own milk for a preterm baby starts from head to toe. What name the organ it will get beneficial by the mother's own milk. Starting from the neuronal growth factors or DHA present in the breast own milk, breast mother's milk contains DHAs, PUFA, long chain polyunsaturated fatty acids, which is helpful for the neurogenesis and dendrite development, which ultimately leads for the good neurodevelopmental outcome. The vascular endothelial growth factor present in the breast milk helpful for the angiogenesis, synthesis of the new layer of the blood vessels, which in turn helpful for the prevention of retinopathy of prematurity. Hepatocyte growth factors, epidermal growth factors, which is present in the breast milk, in turn helps in the maturation of the gut, maturation of the liver, and maturation of the kidney. And insulin-like growth factors, which is present in the breast milk, it increases the erythropoiesis and decreases the anemia in the preterms. When we talk about precisely about benefits, early benefits and late benefits. Early benefits in the NICU and beyond NICU. So early benefits, ultimately they decrease the morbidity, mortality and outcome of the, and then there is a good outcome of the NICU baby. Decreasing the morbidity, mortality in terms of like decreasing the necrotizing enterocolitis, late onset sepsis, retinopathy of prematurity and bronchopulmonary dysplasia. Beyond NICU, there is an improved sensorineural development, decreased dehospitalization in the first year of life, neurodevelopmental outcome by 2 to 8 years. So, if you put a table of a chart and explain regarding how the breast milk, mother's own milk influence on the different diseases in the preterms, if we give exclusive breast milk, if we take a baby with an exclusive breast milk as a 1 and there is a 12-fold increasing in necrotizing enterocolitis risk for the babies, and there is a 3-fold increasing in the risk of developing bronchopulmonary dysplasia for the babies, and there is a 2-fold increase in risk of developing retinopathy of prematurity. Necrotizing enterocolitis. So here we read about this graph representing the x-axis is representing the days of the baby and the y-axis is representing the proportionate of infants who survive free of events, like survive free of necrotizing enterocolitis or sepsis. Pointer. అది పోయింది ఇదా The x-axis is representing the days of the baby and the y-axis is representing the proportionate of infants who live survival free of event, that is anemia necrotizing enterocolitis. If the babies receive more than 50% of the breast milk in the first 6 to 10 days of life, the disease-free survival rate will be higher. If the babies receive around 0.01 to 50%, the disease-free survival rate will get decreased. It means that more than 50% of the breast milk if the baby receives in first 6 to 10 days of life, the proportionate of not getting of NEC or a sepsis will be higher when compared with less chance of getting of mother's milk. So why preterms susceptible for the necrotizing enterocolitis? The main thing is there is a decreased intestinal motility in the preterms, and along with it there is a mucosal lining, immature mucosal lining and immature mucosal proteins, which in turn leads to increasing in intestinal permeability, which in turn leads to bacterial translocation and leads to uncontrolled inflammation and gut barrier failure. And as the immunity of the preterms will be low, that is mucosal immunity and IgA, and this leads to bacterial invasion and uncontrolled inflammation and loss of gut barrier failure and necrotizing enterocolitis. And the good news here with the human milk is, human milk will decrease the intestinal permeability and it will increase the intestinal motility, and it will have a beneficial intestinal flora, good commensals in the gut with the babies who breastfed. And the oligosaccharides, which are the, as I have discussed previously, that human milk oligosaccharides, which are the carbohydrates, long chain carbohydrates, which lining the mucosa will prevent the bacterial invasion. They mimic like an agent and attract the bacteria towards them and prevention of the bacterial invasion. And breast milk also contains IgA, lactoferrin and immune cells, which will further prevent the necrotizing enterocolitis. So human milk is dose dependent. So for every 10% increase in mother's own milk of total enteral feeds, there is the risk of decreasing in NAC by 17%. If more than 50% of the hospital days baby receives mother's own milk, there is a lower incidence of the necrotizing enterocolitis. That is, like if we increasing in 10% each day, the decrease of necrotizing enterocolitis decreased by 17% of each day. So this is the same, which is showing a dose dependent thing. Babies who receive 1000 ml per kg of mother's milk have a less chance of getting NEC when compared babies receiving 100 ml per kg per day of breast milk. So when there is an increasing in proportionate of breast milk in the enteral feeds in the first 14 days of life, the decrease in chance of getting necrotizing enterocolitis. So this is also a dose dependent, that is mother's own milk reduces the risk of late onset sepsis. Each additional increase in 10 ml per kg per day of mother's own milk reduces the risk of sepsis by 19%. Next comes the bronchopulmonary dysplasia. There are so many factors influencing the chronic lung disease or bronchopulmonary dysplasia, that is antenatal, postnatal factors which contribute the release of pro and anti-inflammatory cytokines. Breast milk contain an antioxidant property that might protect the low birth weights from the oxidative stress which was induced either antenatally, postnatally by the lung injury whichever we given, like barotrauma or volutrauma, which shall be protected by the breast milk. So this is a statistically significant relationship between the breast milk and BPD, which showed that then babies who exclusively breast milk have less chance of getting BPD compared to the babies who receive exclusive formula. ROP, the severe ROP. So breast milk in turn have a directly proportional relationship with the severe ROP. So here the empty graph shows that there is retinal detachment in where without retinal detachment in a human milk, babies who receive human milk, and this filled graph shows that the babies who had a retinal detachment, who had a formula milk in their enteral feeds, and who had a retinal detachment. When there is an increase in receiving of the breast milk, there is a decreasing in chances of getting severe ROP. This is also a dose dependent. When there is a breast milk has around 60 to 80% of the volume of total enteral intake contains a breast milk for a baby, there is a chance of getting less chance of getting severe ROP when compared to the severe ROP means retinal detachment. Neurodevelopmental outcome. As we discussed previously, the human milk contains the long chain polyunsaturated fatty acids, especially docosahexaenoic acid, arachidonic acid, which are useful for the neurogenesis, and human milk oligosaccharides, which have a healthy gut in turn NEC, one of the risk factor for a neurodevelopmental outcome. So ultimately it also play an indirect role for maintaining of the good neurodevelopmental outcome. There is an evidence support that beneficial effect of human milk on brain, visual, cognitive development from infancy to adolescent. Denon and colleagues have done MRI-based research on babies who has minimally received 3 months of human milk or an exclusive formula or a mixed at 10 months and 4 years of age. In that MRI, they found that human milk-fed children exhibited an increased white matter development in later maturing frontal and associated brain regions, which found positive association between white matter microstructure and breastfeeding during a severe brain regions. There is a high receptive language scores and vision receptive scores among the babies who are fed with exclusively breast milk. When it comes to the beyond NICU, that is birth to 2 years. So there are extensive studies has been done how the breast milk is directly related to the neurodevelopmental outcome, in which Woher et al. Who has done the dose-dependent human milk and outcome at 18 months of age. And they found that there is for every 10 ml per kg per day increase in breast milk, the mental developmental index increased by 0.53 points, psychomotor developmental index increased by 0.63, and behavior rating scale increased by 0.82%, and likelihood of rehospitalization decreased by 6%. And where they continued the study at 30 months again, they have found similar advantages even at 30 months, where there is 10 ml per kg increase in 0.59 of mental developmental index and psychomotor 0.56 with a behavioral percentile of 0.99 points. And the rehospitalization between the discharge and 30 months was only decreased by 5%. And this was a study done with how the neurodevelopmental outcome depends on who got discharged on breastfed at discharge. And they have made 2 cohorts, one at 22 to 30 weeks and examined at 5 years of age, one at less than 33 weeks, examined at 2 years of age. In both the cohorts, they have a 2.2-fold increase in normal development in 22 to 30 weeks baby at 5 years of age, and 2-fold in normal development in 33 weeks baby at 2 years of age. This shows that significant association between the breastfeeding at the time of discharge and a non-optimal neurodevelopmental outcome. This clearly shows that breast milk not only the nutritive support, they also give non-nutritive support with the neurodevelopmental outcomes. And beyond 2 years, these are the extensive studies, and breast milk feeding brain development at 7 years. Infants who are born at 30 weeks. Infants who received more than 50% of the breast milk in the first 28 days of life, and then MRI done at term age showed that large deep nuclear grey matter volume increased by 0.15 cc per day, and IQ has increased 0.5 points per day, and mathematics, working memory, motor function, everything has been found to be higher as compared to the formula fed infants. And then long-term benefits. Long-term benefits are decreases the metabolic syndrome, decreases the low density lipoprotein levels, decrease less insulin and leptin resistance, which in turn decreases the diabetes. The preterms are more common for going up in serious complications like small ventricular size, heart muscular hypertrophy, poor blood pressure control, which they manifest in adulthood or adolescent with an hypertension, ischemic stroke and poor metabolic function. In this also, the cardioprotective nature of breast milk helps in lower systolic and diastolic blood pressure at the age of 13 to 16 years and has an improved ventricular size and stroke volume, which further decreases the ischemic stroke in the adult age. So many of benefits, though we know so many of benefits, there are so many challenges to maintain this, to provide these benefits for the preterm babies. What are the challenges? Lack of information, lack of emotional support, maternal anxiety, lack of motivation. Extreme prematurity itself have a decrease in milk production with a lower gestational age. Lack of information. Mothers are, preterm delivery itself has a stressful procedure where they have no clue about do we need to express the breast milk, when to express the breast milk, and how frequently what method to be done, and how to preserve it, and how to transfer to the babies. Our babies are going to be started, the baby's mother's milk. When are the baby going to be started? All these questions per day with a lack of information further decreases the breast milk availability to the preterm babies. Lack of emotional support. As there is a separation between the maternal-infant separation and there is a decreased skin-to-skin contact between the mother and the baby, further decreases and loss of emotional support, as we are talking about happy hormone, where there is no happy hormone oxytocin, and there is decrease in breast milk. And maternal anxiety, postnatal depression, which like maternal fatigue, young maternal age, socio-economic status, all this in turn leads to decrease in breast milk. and lack of motivation. This is very, very important, where the team comes into, like gynecologists, neonatologists, lactation support, everyone team together needed for the motivation of the mother to receive the breast milk. I don't say take home message, let's practice. As we know, breast milk is the best, and together we can maximize the preterms receiving the mother's own milk, and in turn which will decrease the mortality and morbidity of preterms, and we can discharge a healthier and smarter NSU graduates. Thank you.
Thank you very much, Dr. Sindhu, Dr. Vijaya Krishnan, Dr. Geetanjali, and Dr. Vinoda Vunnam. So all four of them have taken us through this entire journey, starting from antenatal interventions, intrapartum interventions that can affect the success of breastfeeding. Dr. Vinoda spoke to us about postnatal interventions, lactation aids, and then finally we heard something about use of mom or mother's own milk, which is considered as liquid gold for the preterm high-risk newborns. So I heartily thank the chairpersons, Dr. Surendranath Sir, President State NNF, and Dr. Deepthi Ma'am, expert in IVF and Joint Secretary OGSH, for chairing this session. On behalf of KIMS Cuddles team, may I request Dr. Rohini to please help us out with the mementos, and I request Dr. Pranitha Reddy from our team to please kindly step up and hand over the bouquets to Sir and to Ma'am for chairing this session. Although I'm hoping our faculty will also stay back, I really am very, very grateful, and I'm going to request Dr. Bhavani Deepthi from our team. Can you please come over to the stage and hand over the mementos to our faculty? We'll begin with Dr. Vijaya Krishnan, Director of Sanctum, for a small felicitation. Bhavani, you can come here. Dr. Vinoda, as well as Dr. Sindhu. So we'll quickly move on to the next session. We are running behind time by almost 45 minutes. To do this session, I'm going to invite Dr. Pranitha Reddy. She is consultant neonatologist and pediatrician from our team here at KIMS Cuddles, Kondapur. We are going to now hear about something about Human Milk Bank, and I'm sure she'll be talking about the steps that we have taken to ensure quality control and assurance at our own milk bank that we are very happy that we were able to start last year. Over to you, Dr. Pranitha.
Thank you, ma'am. Good afternoon, everyone. A very warm welcome. So let us discuss today about human milk banking, a simple way to save lives. So in 1980, WHO and UNICEF have jointly declared that where it is not possible for the biological mother to feed their baby, the next best alternative is donor mother milk, and human milk bank should be made available in appropriate situations. So why are human milk banks important? India shares the highest burden of preterm births, that is 23% of the global share, and also preterm deaths, that is 29% of the global share. And 75% of these preterm births can be prevented by simple interventions, one of the most important of them being mother's own milk. So mother's milk is the best form of milk for the babies. Sick babies, premature babies may not always have the luxury of having mother's milk in the first few days, and having a milk bank in the hospital will have a positive impact on the overall thinking of the people working in the hospital. However, it is to be emphasized that the donor milk should only be a temporary arrangement and it should not replace mother's milk. So let us discuss about the importance of human breast milk. Breast milk contains carbohydrates, proteins, fats, vitamins and minerals in appropriate quantities required by a baby according to the gestational age, whether it is a preterm baby or a term baby. What the formula doesn't have and the mother's milk have is various hormones, growth factors, healthy microbiota and microRNAs which help in building up the immune system, microbiota of the baby and the overall development of a baby. So according to the NFHS5 survey, the early initiation breastfeeding rates has increased only marginally from 41.6% to 41.8%. But when we compare it to the rates in 1992, it has increased from 9% to 41%. And the rates of exclusive breastfeeding at 6 months has increased from 54% to 63%. And 14% of under 5 deaths can be prevented just by breastfeeding alone. So WHO recommends that mother's milk is the best form of milk to be given to the babies, followed by donor milk and formula milk. And when we compare the different forms of donor milk, freshly expressed preterm donor milk is preferred over freshly expressed term donor milk, followed by pasteurized donor milk. So human milk reduces the chances of sepsis by 19%, all forms of NEC by 79%, all forms of ROP by almost 30%. It also reduces feeding intolerance, reduces length of stay, and it helps in saving the cost of the parents. It also promotes better neurodevelopmental outcomes. So all of this were discussed by Dr. Sindhu in the previous session, so I am skipping this. For every human milk dose of 10 ml per kg per day, the rates of sepsis has reduced by 19%. And in babies who are fed with formula, the rates of NEC has increased by 1.87 times. Any amount of human milk reduced all forms of ROP and severe ROP by 24%. So coming to the history of human milk bank. So wet nursing has been practiced since centuries in our country, and the first human milk bank was started in Vienna, Austria in 1909. With the beginning of HIV in 1980s led to the closure of many human milk banks, and in 1985 the Human Milk Bank Association of North America has issued stricter guidelines for the establishment of milk banks. One country we can all follow is Brazil, where it has 40% of the global milk banks. Coming to India, the first milk bank was started much later in 1989 in Dharavi, Mumbai by the legendary Dr. Arnida Fernandez. It was known as the Sneha Milk Bank. At present, there are almost more than 100 to 110 milk banks in India, and in Telangana there are 8 milk banks, out of which 6 are present in Hyderabad. So coming to the milk banks, the lowermost type of the milk bank is lactation support units, which should be present at all delivery points. Here we need to give support for the mothers and counseling for the mothers. The next level is lactation management units, which is to be present in district hospitals and sub-district hospitals. Here there is no facility for pasteurization of milk, but there should be facility for counseling mothers, expression of milk, storage of milk and dispensing of milk to the babies in need. The next form of the highest form of a lactation support unit is Comprehensive Lactation Management Center, which is to be present in all medical colleges with NICU facilities and large district hospitals. Here, in addition to the others, there should also be facility for processing of the donor human milk. So this is a comprehensive lactation management center where antenatal counseling should be given to all the mothers. Early initiation of breastfeeding within the first hour of life needs to be started. On-demand breastfeeding needs to be promoted. Lactation support should be given throughout the breastfeeding journey. Kangaroo mother care needs to be also supported because it increases the chances of exclusive breastfeeding by 18%. And when mother's milk is still not possible, then donor human milk should be made available. And from the CLMC, the donor milk is also given to the other smaller units. So where should be the human milk bank? Human milk bank should be present within the NICU or in close proximity with an area of 250 square feet with uninterrupted power supply. What are the equipment needed for the establishment of human milk bank? A pasteurizer is needed, a sterilizer, a deep fridge, a laminar flow unit, breast pumps and bottles, hot air oven and autoclave, and a human milk analyzer is optional. So the most important components of functioning of human milk bank is counseling. This plays the most prime role, followed by expression of milk and use of breast pumps, followed by donation of milk. So who are the beneficiaries of donor human milk? All the very low birth weight babies, premature babies, babies who are small for gestational age, growth restricted babies, and babies with Doppler abnormalities like absent end diastolic flow or reversal of flow are the most important beneficiaries of donor human milk because they all have increased chance of necrotizing enterocolitis. And all babies with NEC or feed intolerance, all babies post gastrointestinal surgeries are all the beneficiaries of donor human milk. And other indications, lesser indications are babies, mothers with multiple pregnancies, adopted babies, and babies with absent or insufficient lactation. Donor human milk is not intended for term babies, discharged preterms, and mothers who otherwise have healthy babies but with insufficient mother's milk. What are the functions of milk bank? So functions of milk bank is selective donor recruitment, screening of the donors, sanitary milk expression, temperature controlled milk handling, pasteurization, bacteriological testing, temperature controlled transport, followed by milk allocation to the infants. So before establishment of the milk bank and also after the establishment, we need to give regular training to the staff regarding the counseling of the mothers, both antenatal as well as postnatal, regarding pumping of milk, regarding sanitary collection of milk collection, and regarding hygiene measures, cleaning of the milk bank, quality control measures, maintenance of records, and the process of pasteurization. What is the manpower required for the human milk bank? We need a director, a milk bank officer, at least 2 lactation professionals who are the pillars of milk bank, a technician, attendant, and a microbiologist. So who can donate milk? Mothers who are healthy, who are voluntarily donating milk without any incentives, without any force are the donors who can donate milk. And where can we find these potential donors? So the attendants of babies in NICU, mothers in the postnatal wards or the kangaroo mother care wards, mothers who are coming to the follow-up clinics or immunization clinics, and lactating women among the staff are all the potential donors. What are the screening criteria for the donor mothers? So on history, we need to find about any history of acute illness, any chronic infections like HIV, hepatitis B, hepatitis C, syphilis, any chronic autoimmune conditions with exacerbation during the pregnancy which needs any immunosuppressive drugs, any history of transfusions, any history of addictions, and on physical examination there shouldn't be any signs of infection, any signs of rash of herpes or varicella zoster, or no COVID illness, no history of chronic cough in the last 2 weeks. What are the contraindications for milk donation? So mother who has received blood transfusion products, who has received organ or tissue transplant, who has received permanent tattoo or body piercing in the last 1 year are not eligible to donate milk. And mothers who have alcohol intake or use tobacco, nicotine or any other illicit drugs are also contraindications for milk donation. So we also need laboratory evidence of negative HIV, HBs, AG, HCV and syphilis reports from past 6 months. CME report is not usually collected because CME is killed during pasteurization. So what medications can be taken by the mother who donates milk? Mother who is taking multivitamins, calcium, iron, thyroxine, orohyperglycemic drugs, insulin, hydrocot, oral contraceptive pills, progestin only pills can donate milk. All the mothers who are taking other medications, it is better to consult once with the doctor before donating milk. So we need to, after screening of the donor, we need to take a consent form. It should be in the local language that there is no charges being taken for milk donation. It is a voluntary donation without any incentives. And it should also be mentioned that their milk is being donated to the sick preterm babies. Consent should be taken both from the donor as well as the recipient. So mother needs to be educated regarding hand hygiene, regarding hand wash before expression of milk, cleaning of the local area, breast and chest, not to use any soap, regarding milk expression both manually as well as with the pump, and handling and storage of milk, and sterilization of pump. So complete asepsis needs to be taken while expressing milk and collecting milk and storing milk. So we should also explain to the mother regarding manual milk expression, because sometimes manual milk expression can be more effective when compared to expressing with the electric breast pump. So this is our milk expression area. Usually hospital grade breast pumps are preferred to express milk, and mothers should be educated regarding expression of milk as soon as possible within the first 1 hour of life, and to express milk at least 8 times in a given 24 hours of a day. Double pumping, where pumping is done from both the breasts, increases milk expression by at least 18%. So most of the mothers have this doubt whether if they are donating milk, will it be sufficient for their own babies. So we need to reassure them that lactogenesis 2 is autocrine mediated, and after day 9, the more is the breast emptying, the more is the milk production. So the milk supply to their babies is not going to be reduced by donating milk. After milk collection, it needs to be stored in containers. Usually BPA-free plastic containers or glass containers are preferred. Steel containers are not usually preferred, and milk, when it is kept at room temperature, is stable for 4 to 6 hours. In a refrigerator for at least 24 to 36 hours, and in a deep fridge, if it is unpasteurized, it is safe for 1 to 3 months, and pasteurized milk is safe for 3 to 6 months. So after collecting milk, if it is not in the hospital itself, it needs to be transported. Transported should be again done by cold chain in ice boxes, and we have ambulance facility for collecting milk. And till it is used, it should be stored in a deep freezer. And all the milk collected needs to be labeled with the name of donor, date of expression, donor number and the volume of donation. So if it is mother's own milk and if it is to be used within 24 hours, we usually refrigerate it at +2 to 4 degrees centigrade. And if it is not to be used within 24 hours, and if it is donor's mother's milk, we usually store it at deep freezer at -20 degrees centigrade. So after taking consent, taking history, physical examination, serological test, and if the mother is eligible for donation, we usually collect milk and store it in the deep freezer, and later when milk is needed, pooling is done. So before pooling also after pooling again pre-pasteurization testing is done, and if it is positive, the milk is discarded. And after pasteurization again testing is done, and if the milk is still positive, we usually discard the milk. And if it is negative, then the milk is stored in the deep freezer till it is used further. So this is our milk storage area. The first picture is showing the unpasteurized milk which is stored in the deep freezer, and the second and third picture showing the pasteurized milk which is stored before receiving the reports. So after collecting milk and storing it in the deep refrigerator, whenever we want to pasteurize the milk, thawing is done. Thawing is either done by placing in the milk under running water, but what we usually do is place it in the refrigerator overnight. The time should not pass more than 24 hours. Or if milk is needed immediately, we usually also thaw it in water bath at 37 degrees centigrade. Never refreeze thawed milk because it leads to hydrolysis of triglycerides.
So this is our thawing area with the feeding fridge, and the frozen raw milk is usually thawed overnight in the refrigerator. So this is the milk sterilization area and thawing area. So after thawing, usually pooling of milk is done. Pooling is done under laminar flow, under complete aseptic precautions. Whoever is doing pooling has to wash their hands, wear gloves, cap, mask, everything, and pool milk under complete asepsis. And after pooling, milk is again collected into bottles. Usually milk from 3 to 5 donors is accepted. So after pooling, again pasteurization is done, and if the colony count is more than 10, we usually discard the milk. So this is the automatic Sterifeed pasteurizer. It contains 2 chambers. The red chamber is the part where heating is done at 62.5 degrees centigrade for 30 minutes. This is the Folder's method. And after heating, cooling is done. So we initially let the water pass into the container, and preheating is done. When preheating is done, temperature reaches 62.5 degrees centigrade. Then the milk cage is placed into the red chamber first. And after 30 minutes, it gives us an alarm. And post that, it is shifted into the blue chamber where milk is cooled at 4 degrees centigrade for 10 minutes. So this completes the pasteurization process. The entire process is again monitored with a temperature probe which is connected to the computer. So pasteurization kills all the bacterial microbes. It also inactivates CMV and HIV. So the entire process of milk collection, storage, pasteurization is all temperature controlled and should be monitored very diligently. So after pasteurization, again milk screening is done post pasteurization. Cultures are done for every batch, and till the culture reports are available, they are labeled with a red sticker, and once the culture reports are available, they are labeled with green stickers, and then only they are ready to be given to the babies. So post pasteurization, we again label it with the batch number, the volume of milk, the date and time of the pasteurization, and the date of expiry. So this is the microbiological reports. Only once the reports are available, the milk is dispensed to the babies in need. And deep freeze is usually used to store the milk post the pasteurization. Temperature is -20. It is preferable to have at least 2 deep freezers, one to store the unpasteurized milk and one to store the pasteurized milk. And in the refrigerator, we usually use it to store the entire day's milk for cooling and for mixing for pasteurization, and also to thaw milk overnight before disposal. So strict records need to be maintained regarding the heat treatment time, the temperature, the microbiology reports, the time of moving to the freezer, and the containers per batch. Records need to be maintained at least for a maximum of 5 years, because incubation period of most of the infections is usually days to weeks. So the milk is donated only by prescription. We need to prioritize babies who are premature and who have NEC. And the milk delivery, if the recipient is not in the hospital, is usually transported in sealed bottles or over ice packs. Milk needs to be provided again at 37 degrees centigrade. So this is the process of the human milk bank functioning. First, the donor mother approaches the CLMC where she is screened, consent is taken, milk is donated, then it is stored in a refrigerator, then thawing is done, followed by cooling of milk and pasteurization of milk. Post pasteurization, microbiological testing is done, and once the reports are available, till milk is stored in the refrigerator, deep freeze, and on prescription of the doctor, the milk is thawed and given to the recipient. So this is our human milk bank, which was started in November last year. Governor has graced the event, and there were many donor mothers who has donated milk, and they were all facilitated in the event. We also had a lot of media coverage which helped in inviting more other donor mothers for the milk donation. And these are all our premature babies, 26-weeker twins in the first picture, again 26-weeker twins in the second picture, and the third picture is a 26 singleton baby. All of them were transported in utero, they were delivered here, they were given donor human milk in the first few days, and they were discharged on mother's own milk. None of the babies had ROP or IVH or BPD. So I would like to conclude saying that milk banks are the way forward. We need to protect, promote, and preserve the liquid gold. Pasteurized donor human milk needs to be only a short-term life-saving modality, and milk bank should never replace mother's milk. Thank you. Thank you very much, Dr. Pranitha, for enlightening us on human milk banking, the process, the quality assurance, the documentation that it involves. It's definitely the way forward for our country, which is the home to the largest number of preterm babies, 27 million babies, of which at least 3.5 million babies are born preterm and low birth weight every year. This is the biggest demand versus supply gap that we have in the domain of preterm care, and it is said that India needs much more milk banks than the existing around 90 odd milk banks that we have to subserve to this huge load of preterm babies. Are there any quick questions for the speakers so far? I think most of the speakers are here for the first few sessions. Now, while we are proceeding, it's also my duty to thank Serum Institute today for being a part of this CME and for supporting the cause of breastfeeding. Thank you very much. Serum Institute has always been a forerunner when it comes to quality immunization, and we will probably call Mithun and his team in a little while again after the next talk, the debate. So please stay around. The next session is going to be a very, I would say, much awaited session where we have the war of titans who are going to clash on galactogogues, whether this is a boon or a bane. Now, realizing how significant this topic is, we have two very interesting and very enthusiastic, highly academic speakers, and we have a very, very important member as the chairperson for this very difficult debate. So I'm first going to invite the chairperson, Dr. Jasmine Rath, consultant obstetrician from Apollo Cradle Hospital. Thank you, ma'am, for being a part of this. Would you like to tell us something?
So thanks, Aparna, for calling and inviting me here. So I think the next topic is galactogogues, boon or bane. So it's quite interesting, and we are all eagerly waiting, and we like to invite the for who is going to talk is Dr. Vadije Praveen Rao, consultant neonatologist, Cloud9 Hospital. Welcome.
So Dr. Praveen is a neonatologist who trained at Fernandez Hospital, and after a brief tenure at Paramita, he is now associated with Cloud9 Hospitals at High-Tech City. He is going to speak for galactogogues, and to speak against galactogogues, we have Dr. Sneha Madasu, who is assistant professor pediatrics and trained lactation consultant from Nilofer Hospital. You will realize as they speak that both of them are extremely scientific, and they are going to back up their arguments with a lot of scientific evidence. And over to you, and we are awaiting a great clash.
Thank you, ma'am. Thanks for your trust on us. Thank you, KIMS Cuddles, for giving this opportunity, and Aparna ma'am, special thanks for you, and Dr. Pranitha for coordinating all the sessions very well. So I would like to talk next 15 minutes. My topic is very short. Don't keep your expectations much. So it is just a 15 minutes talk. I will talk about the galactogogues theory and also about the evidence for usage. So all of you know we are using a lot of galactogogues, herbal and pharmacological. So most of the clinicians, this is one practice where herbal medication is prescribed by the most of the physicians. So coming to just dwelling into the main topic of galactogogues, I will just briefly discuss about the lactation physiology. So as already you know that lactation consists of three phases: lactogenesis 1, 2 and 3. Lactogenesis is 1 will start from the mid-trimester, then it will be till the first 2 days of the postpartum. So the main changes that will happen during the lactogenesis 1, as you know, the development of the breast glandular tissue. So that is regarding the lactogenesis 1. It is mainly by the progesterone and estrogen. So lactogenesis 2 is the milk coming in. So the milk, actual milk comes in. That is from the day 3 to day 8 of postpartum. So this is more of endocrine control, where the progesterone effect will go and there will be effect of the prolactin. So then the lactogenesis 3 is the more like the high amount of milk volume coming in because of the sucking and emptying of the breast by the oxytocin. So these are the basic concept to understand the galactococcus. So this is one image showing how this lactation is well orchestrated in the brain. So by sight of the baby, odor of the baby, sound of the baby, the hypothalamus will stimulate prolactin releasing factor. PRF means prolactin releasing factor. So that will stimulate the prolactin. So we have prolactin inhibiting factors also, particularly dopamine. Dopamine is the neurohormone that will inhibit the prolactin. So this prolactin will act on the epithelial cells and it tightens the junctions and it will produce more lactoalbumin and milk synthesis. That is the pathway. So then there will be positive feedback loop on the milk synthesis by human growth hormone, and then we have insulin growth factor, and these are all factors also acting on the milk synthesis. So coming to the feedback loop, whenever the milk volume increases in the breast, there will be a feedback loop called as FIL. So factor inhibiting the lactation will inhibit the prolactin production. So that's why the proper emptying of the breast is recommended for the good milk production. So this will complete the lactation physiology. The drugs we use commonly, dopamine, which act on the antagonize the dopamine, domperidone and metoclopramide. They will antagonize the dopamine and increase the prolactin. So that is the main physiology why we are using those galactococcus. And most of the herbal medicines also act here only. They will also produce more of prolactin. So they will going to work if the mother's prolactin value is low baseline. They are not going to work if the mother's prolactin value is high at the baseline. So the main mechanism is that. So coming to the so we have the main reason why we write the galactococcus is lactational insufficiency, right? So the primary lactation insufficiency is when there is a problem with the phase 1 and 2, that is lactogenesis 1 and 2. So as we know, the mammary tissue is not well developed, like hypoplastic breast or any surgeries has done, or because of the most common we encounter retained placenta. Because of that, the progesterone is high and there is no placental, the progesterone will inhibit the prolactin production. So these are the reasons for the primary lactational insufficiency. Along with that, obesity and stress, smoking and PCOS. These are all the reasons for the hormonal lactational insufficiency. So coming to the secondary lactation insufficiency, as we already discussed this, the feedback inhibitor of the lactation. Improper emptying of the breast will result pooling of the FIL and that will inhibit the thing. So most of the literature tells that 15% of the primary mother will have the lactational insufficiency, 15 out of 100. But the preterm mothers will face more problems because of the breast immaturity, the development. The breast is at the development phase of the glandular proliferation, and mother having comorbid illness, and there is a secretory activation. The prolactin production will be delayed in 3/4 of the preterm mothers. So that's why we work more on the galactococcus even in the history for the preterm mothers, not for the most of the term mothers. So these are the common compounds they are documented in the literature, but we use little among them. Domperidone, metoclopramide from the pharmacological side, herbal. Without knowing the composition, we are using some or other brands of Ayurvedic granules or capsules, which will majorly contains shatavari, that is asparagus, then fenugreek, and then they will contain, most of them contain garlic. So these are the three main components of the galactococcus herbally used. Coming to the Domstal, as we already discussed, this is based on the dopamine receptor antagonist, and this is the most commonly used galactococcus. The evidence came from preterms, not for the terms. So there are 3 RCTs compared in a Cochrane review in 2012, and also other systematic analysis also done, where it has shown that it will decrease the milk volume around 50 ml to 150 ml. So roughly around average of 90 ml, it will decrease average milk volume. it is not for one baby. This is for a group of mother and infant pairs that has to be considered when we interpret these results. So, but as we see, there is no difference in the breastfeeding rates overall. But when the baby is in NICU, they have increased average milk volume by this much amount. So then the side effects profile, as we know, the domstal work on this antagonism of domperidone. Domperidone. So then the side effects will be dry mouth, headache, and GI disturbances will be there. So there are so many concerns about the safety of the domperidone. I am going to support the safety of the domperidone. Dr. Sneha will fight against that. So the main the concerns were it will antagonize the potassium channel, and it will increase the AP action potential duration. By that, it will increase the QT prolongation. So if the mother is taking already some proarithmetic drugs, it will cause the prolonged QT and will result in the Torsades D points. That is the hypothesis behind the concern. So, but the evidence for safety came from one of the important studies, thorough QT study. It was done in Belgium 2012. So, where they have taken 44 healthy adults and they have given different doses like 10 mg QAD to 20 mg QAD, which is generally more than what we prescribe. And there is no significant QT prolongation in that study. And the main limitation of the study is they have not evaluated the supratherapeutic doses, and they have not looked into the drug-to-drug interactions. For example, if the mother is taking grape juice and also this domperidone, then it will cause long QT, because grape juice is, both of them are the proarithmetic potential by causing the increased level of the domperidone. The grape juice will cause the the inhibition, and it will increase the domperidone levels. So those type of drug-to-drug interactions were not checked in that study. That is a limitation, but still it has shown there is no QT prolongation in that study. And other cross-sectional observation study has shown the hazard ratio is less. So even the hazard ratio is 2.25, the confidence interval is touching the 1. So they said it is not statistically significant to worry about the domstal use. And as we see, to support the domperidone use, across globe there is an increased trend of usage of the domperidone. We see Australia, Canada, England, all the countries are now using the domperidone left and right. So in the Australian, 100% of the NICUs, by questionnaire, they said they are using domperidone once in other baby. And in the Canada, 1/3 of the obstetricians are prescribing and neonatologists. And the trend is increasing from 15% to 32% over last 10 years. And England, there is a 3.8 times increased usage of the domperidone. The main reasons why they are prescribing is for the preterms, mothers with section, obese mothers, and also diabetes mothers and primary mothers. And even Dutch people came with one protocol of a clinical protocol how to prescribe the domperidone. So they have in their national journal, which is a standard, they have published this protocol. So they have the algorithm for the general physicians also, they have given the algorithm, this algorithm. So if the mother is producing less milk, then the lactation consultant has seen the mother, 2 lactation visits by the specialist done, then they have done the screening for the ECG, QT and family history. It is absolutely clear. So then they prescribe the domperidone. So they have given a prescription format for the Dutch. So as we are the clinicians, we should have this checklist in mind before prescribing the domperidone. Always screen for the history, or ask for the history of any arrhythmias in the family. That is very important. Sudden cardiac deaths, unexplained deaths. Second, if the suspicion is high, or if the clinical description, if we want to do an ECG, it can be done. So, and that ECG, if there is a long QT more than 0.44 milliseconds, it is better not to give. Or it develops after the this thing, then we have to stop. So then we have to have ongoing care and monitoring for the domperidone. That has to be remembered. It should not be like prescribed and left like that. So, and it has to be written lowest possible dose, like 10 mg TID. That is the lowest possible dose that is documented in the literature. And the dose has to be stopped with the tapering, should not be stopped abruptly, because it is working on the hormone level. If you suddenly stop, the hormones will not get back. So it has to be stopped slowly by tapering. If after stopping, if the mother's milk suddenly decreases, then you restart the dose with half, so that it will be like a slow weaning for you. And always document before prescribing the domperidone. These are the contraindications, these are the risks. With the documentation should be proper. So, but this will not work for all. As we discussed, there are 30% of the non-response mothers. So how to pick them? So the mother who is obese, the studies have shown the response with the domperidone is less, because the TLR immune signaling pathway is one that will be having some effect on the less response. And if the mother is having already borderline, the high serum prolactin at the initiation, there is no point in once again hitting hard on the prolactin. You have to take care of other aspects rather than prolactin. And nulliparous women are more sensitive compared to multiparous. In multiparous women, lactation failure is a multifactorial. It will not be acted by only the prolactin. And the gestation age and timing of treatment based on that. So one study was done for the preterms, Empower study, which has shown even you start less than 17 days, before early or late initiation, there is no difference. So you can start early also, and there is no difference between the effects. So I will discuss one slide about the metoclopramide. As we know, this is the most commonly, second commonly prescribed drug, and with a different dose regimen, 10 mg TID. The days duration is also 5 days to 21 days. Duration, most of the obstetricians and pediatricians write. So it has shown that it will increase the milk product volume, but at the cost of this, the drug will cross the blood-brain barrier. So already if the mother is having at the verge of postpartum blues, the chances of depression will be high. So that's why it's better to have a screening for the depression and then start, or it has to be a second line when the domperidone is not going to work for the mother. So that is the one. So this is the brief summary, as we already discussed this. Other pharmacogalactogogues are like antipsychotic, sulpiride, and growth hormone. These are all not practically possible. Metformin has shown in insulin-resistant mothers. It has shown in the initial studies promising, but further research is needed. So whatever I said, the positive things, these have some limitations. These points will be discussed next with the Dr. Sneha. The sample size problems, most of the have less sample size. Selection bias, most of the dropout from the study population are there. So the risk of selection bias are there. So we don't know the baseline milk production, and they are like groups, not the single mother and baby pairs. That is the main limitation of these things. Coming to quick look on the herbal galactogogues, our ancient literature, Charaka Samhita, Shushruta, all are having wealth of knowledge on the herbal galactogogues. This is fenugreek. In the Telugu, it is menthulu, I think. Yeah. So this is consumed as herbal tea. It has shown good evidence for the galactogogue purpose. There are almost RCTs also shown evidence, but there is no meta-analysis because of the methodological problems. Most of the time it is well tolerated except for the diarrhea and unusual body odor like maple syrup odor. Shatavari is the evidence is there for the increasing milk volume and weight gain. So among the most commonly used is garlic. Garlic is having a lot of advantages. So the big list of advantages it is having. The main problems we have to remember, we know the garlic advantages, but the problems are it is having a blood thinning effect also. If the mother is already using the drugs that cause the blood thinning, then it has to be cautious. We have to tell them the consumption should be less. And gastric acidity also one of the problem. So that has to be taken with a pinch of salt. Moringa is associated with better weight gain in the babies. That is, moringa is, anyone knows this? Drumstick leaves powder, and then ginger. Yeah. So fennel is like soap water also consumed by the mothers. That has also shown one of the galactogogues, and also most of our capsules will contain these combinations: garlic, shatavari, fenugreek, and all that. So this is the last but one slide of this study was done at Paramita, my previous affiliation. So where we have done a QI to improve the mother's milk. The QI has initial phase has shown good results with the counseling. Second cycle we did with the breast pump provision to the mothers, that has also shown the good result. And third cycle we did with the galactogogues, domperidone, that is given as a prophylactic, not a therapeutic line. So the day one of the delivery we have given, the evidence for that is not there in the literature, but we thought the most of the preterm mothers, they will get advantage by the prolactin stimulation. So the blue line shown down is the mother's own milk. The red line is the baby feeding volume. This is for the first 14 days. So as we see, on the day 1 we started on the domperidone, by day 5, the milk volume is increased to 130 ml. The baby feeding volume requirement is 108 ml. It crossed the baby demand. And after stopping, we have seen a phenomenon like this is a plateau. Once again it went down. So then once again we carried more on the pumping and counseling. Once again the milk volume increases. So this plateau effect we have to remember. This is seen even with the Empower study also, the same phenomenon is seen, and even with our study also this is seen. But among all intervention, this QA has shown less, this cycle has shown less milk volume compared to the counseling and the breast pumping. So this is the Academy of Breast Medicine clinical protocol. So already we discussed these points. Medical evaluation for the low milk supply is very important. Then frequent emptying is the key. So if the emptying is not good, then no drug is going to help. So galactogogues won't work if breast drainage is infrequent, inadequate, and they are not endorsing the galactogogues, ABM. Thank you.
Dr. Praveen, for going all out and giving us so much of convincing reasons for using galactogogues for promoting lactation. But we have not heard it all. And to convince us why we should not use galactogogues, here comes Dr. Sneha. She is assistant professor in pediatrics Nilofer and a lactation consultant. So at the end of this talk, we will again have rebuttal by Dr. Praveen, and then we will conclude with the comments of our judge.
I hope this will be an engaging and an interactive session. So whenever I ask a question, please raise your hand so that we can send a mic to you. A person will be ready with the mic.
Can one of us please check if it's coming on YouTube or the presentation? So Sneha has some questions. You please, he will be here with the mic. Whoever wants to answer, please raise your hand. The mic will be brought to your chair.
Hello, happy World Breastfeeding Week. I am Dr. Sneha. I am a pediatrician and a board certified lactation consultant. I am working with Nilofer as an assistant professor, and I have a network of my own which is called Nurture Network. I am passionate about breastfeeding because one, it is such a huge public health intervention, and it is also deeply personal for every woman. And it is so sad to see that simple things like positioning and attachment, early initiation, and just basic knowledge which could have improved breastfeeding rates and saved so many lives and saved so much pain for mothers, that is not being done despite advances in ventilation and very fancy drugs. So my aspiration is to fill that gap in the small baby steps which I can take. So yeah, this is me. I'd like to open with a case. So this is what we usually see as pediatricians, right? So we have a baby who's with us from a very long time. It was a 32-weeker, stayed with us for about 2 weeks. Then we did a lot of counseling, and at discharge, the child was discharged on exclusively breastfeeding. Now the baby has gone home, and now the baby is 2-month-old. The mother has come for follow-up, and the mother says that since past 3 days, the baby has been restless at the breast. The baby sucks for some time and pulls off. And then the baby cries. And the baby is hungry all the time, but then lets go of the breast within a couple of minutes. And till the last follow-up, the baby's weight gain was good, but now it's just hanging on a borderline, slightly going downwards, the weight gain per day. So can anyone think of some DDs? Not the pros, someone from... Anyone? What could this be? No one? So the pediatrician in follow-up thought, okay, faltering of milk supply is so common in a preterm mother. like Praveen sir was saying, the the lobulation of the breast alveoli happens during the pregnancy, especially during the last trimester. And because the preterm mother doesn't have the benefit of all these hormones, some amount of lactation failure is, very common, but we can prevent them by good counseling. But still, mothers do have this late faltering of milk supply. So that is what the pediatrician thought. And then she thought that the baby is restless because of the poor flow. And that is why the baby is not gaining on EBM. The baby was gaining on EBM exclusively, but once the child was exclusively, shifted to direct breastfeeding, the baby is not gaining well. So she gave Domstol, 10 mg BD. And then what happened? First case, again in this we'll divide to 3 scenarios. One, the baby's behavior at the breast got even worse. Now he only prefers to drink from the cup. Earlier he was drinking directly on the mother's breast. Now he only prefers to drink from the cup. And the mother says that her milk is even more thin now. And the baby is now sputtering and coughing. What could have happened? Anyone? Excess 4 milk. My kitchen.
Fast let down?
Fast let down, yeah. So there's an oversupply. This mother was pumping in our NICU. She was doing everything well. The baby has adjusted. Now, due to all the excess pumping, and she was giving EBM after going home also, she was landing into a oversupply mode here itself. The baby being restless at the breast could be oversupply also. And not assessing the breastfeeding well, coming to a hurried diagnosis, the pediatrician gave Domstol, which sort of pushed things even further. Second scenario, the same scenario. What I said, that the mother came with same history, was restless, and the pediatrician gave the Domstol. This is the second scenario. When the baby's behavior at the breast hasn't improved, it's still, the baby is still restless at the breast, doesn't want to feed continuously. The baby pulls off and cries, but takes EBM from the cup, and EBM expression volumes are slightly better than earlier, is what the mother is saying now when she came for the follow-up. And hunger signs and crying has settled down after giving formula, and the weight gain, which was faltering then, now is better. What could have happened here? The same scenario could be so many things. That is the point I'm trying to make. So this could have been, the mother actually had low supply, and Domstol actually helped her. But then things, of course, we'll come to this back later. And the case scenario 3 is, the same baby in the follow-up has shown no improvement. The baby still pulls off and cries, accepts milk from a cup. But then the mother reports that there was some congestion. She gave nebulization. After that, the baby is accepting from the breast. What could have happened here? The baby had cold. That is why the baby was restless at the breast earlier. When the mother came after 2 months, the baby was feeding on the breast well. Only since 3 days, the baby is fussing at the breast, letting go. We need not assume that it is a low milk supply. Maybe the baby's nose was just congested. So the point I'm trying to make is, if the only tool you have is a hammer, everything looks like a nail. So it's important to know that there are many things that are possible, that can go wrong, and many things that can be done to improve things. So don't hit everything with domperidone or perinom, is the point I'm trying to make. So the outline of my talk would be that Bain, Praveen sir has talked about why galactogogues are useful, and I'm not contending with anything which he said. It is based off research, and I fully agree that in preterm mothers, the amount of milk improvement that you're seeing is good. But then what is the downside of it is what I'm going to talk about. And what I want to show is that we use galactogogues way too often, and they aren't anyway efficacious, and they actually distract us from the real things which help the mother. And they often cause harm. So let's change. That is the outline. So this study, this is a British Columbia study from Canada, where the exclusive breastfeeding rate is for 41%. This is a huge study with almost 2 lakh mothers. And the study showed that 1 in 5 mothers are being prescribed, have used domperidone in the first 6 months of feeding. And in preterm it is 1 in 3. So why should a term mother, 20% of term mothers have this issue? Like sir was saying, about 15% of mothers do face lactational issues. They can be also primary and secondary. It need not be always that the biology is at fault. But then, like, you know, how the WHO says that the section rate should be something between 5 to 10%. Like that, the primary, any insufficiency of the mothers usually should hover about 15%. Then you can see that way Canada is slightly okay doing. But then in US, about 50% of the mothers are using galactococs. I tried to check for literature in India. I couldn't find any. I hope we will together do some study. And in Australia, an audit showed that in a teaching hospital, in a tertiary teaching hospital, more than 5% of the mothers were using galactococs before discharge. And this steadily increased in from 2000. In 2000s it was less than 0.5, and now in 2013 it was more than 5%. So one speculation is that, you know, over the years the importance of breastfeeding has been recognized well, and mothers are more interested to breastfeed. Physicians are more willing to, you know, support her, and therefore instead of resorting to formula, we are going for galactococs, and that is okay. But then overall, if you see, what I have a problem is that in this audit, about 60% of the mothers who had been put on galactococs didn't have a lactation consultation at all. So there was some issue, but the issue was treated with the hammer, which is the galactococ, instead of using other tools, instead of assessing what is actually going wrong. So coming to the point that, you know, galactococs aren't actually that great for term mothers. For preterm, I agree that, you know, there has been problems, and for mothers who have other medical issues, there's nothing wrong using them. They are one among the many tools in our toolbox. But for a healthy term mother, when systematic reviews were done, I'll just read it out, and you can see this is a Cochrane review. It says that limited and very low certainty evidence is there to support galactococ use, and to see if there is weight gain or if there is exclusive breastfeeding rates improvement at 3 months, 4 months, 6 months. Galactococs haven't proved anything much. And when it comes to milk volume, for a healthy term infant, it is not that beneficial. If you can see the language used, there is some evidence from subgroup analysis that they may be of some benefit. And there is substantial difference among galactococs again. So this slide is only about the pharmacological agents, not the herbal ones. And it reports how metoclopramide influences the change in weight gain in the infant. So if I remember right, in preterm, sir, I think the increase in milk volume is about 40 to 60 ml at least. And that constitutes at least 40 to 50% of the milk volume for a very low birth weight baby. But then this, if you see the milk volume raise in a term baby is around 63 ml, which is not even a single feed. And if you see the weight gain, the amount of weight gain that is improving with metoclopramide is 23 grams over 15 days. That means not even 1 day's weight gain in a month. So we need to understand that, you know, galactococs are not as mighty as they seem in term mothers. They are not, you know, the be-all, end-all of solving milk supply problems when the mother is physiologically normal. And when it comes to perinorm, there have been 5 RCTs. Among them, three studied normal mothers with normal birth, and 1 studied relactation, and 1 studied mothers, babies who didn't gain enough weight, that is less than 500 grams in the first month. Even them, they did not find any difference in the milk volumes or in the breastfeeding duration. All of these are the recent RCTs. The older RCTs, some of them did find some difference, but then again, perinorm, they did find some difference, but then the studies had less rigor and we can't fully rely on them. And one thing which I found was interesting is one of the RCT found similar effect between perinorm and domperidone, and that brings a doubt on domperidone, sir. If perinorm doesn't have any effect on term mothers, does domperidone have any effect on term mothers is the question I'd like to ask. So what are the limitations of use? So I do agree that milk volumes are increasing, but then the limitations are that there are some mothers who respond to the drug and some others who don't respond to the drug, and you don't have any way to know who are responders and who are non-responders, and the dose response relationship is not uniform, and some mothers will respond at a lower dose, and if you see the studies also, there's a lot of difference, and some mothers need a higher dose, and there is a difference between these two mothers, but then it plateaus down. So after a point, the increase in the dose is not going to increase the milk supply, and even if at a good dose, I think the Cochrane review which Praveen sir was pointing out shows that there's a plateau effect. That means after a point, you just continuing the same dose is not going to help improve matters with respect to the milk volumes that the mother is able to produce. And in Empower trial, which sir had quoted, which is one of the largest RCTs which on domperidone, it did show this Empower trial is about preterms. I do agree that preterms are being benefited, but I was surprised to see that even in preterms, after 28 days and at term corrected gestational age, and after 6 weeks after starting domperidone, ultimately there was no difference. There were no significant changes. So this initial milk volume raise is only a short-term benefit. It's not going to improve things in the long term. And another limitation is, like even Praveen sir had emphasized, that all these galactogogues are going to be ineffective if there is if the milk drainage is suboptimal. And this is not a study, but an expert opinion that milk supply will be helped by galactogogues if already the mother had achieved a certain milk supply and then there was a dip, rather than mothers who were not stimulated in the early many weeks, the milk supply has not been established, and now if you want to raise it, galactogogues are not going to be that effective. But if the mother had achieved this, like for example in our case, the NICU mother had achieved some amount of milk volume and then there was a drop. In such cases, galactogogues seem to be more effective. So what are the side effects? Like I think sir had covered many of them, so I will not waste time here. But this simple thing to remember is metoclopramide crosses blood-brain barrier. It causes postpartum depression. I don't know why we are still using it. Already postpartum depression is so prevalent among mothers and especially among NICU mothers. And to add upon that, you give her perinorm, it's bad, it's evil. And domperidone, QT prolongation, I agree sir, and I'm not going to base my argument about saying that domperidone is bad because of QT prolongation, because like sir said, the risk is very low. So I'm going to base all my points against galactogogue, saying that it is just an overused tool instead of that it is a bad drug. It is a good drug with a relatively good safety profile. Unfortunately, it is banned by the US FDA for supply for any other reason except for gastrointestinal causes. So in the US, you can't get domperidone for lactational help. But then in other countries, it is available. And the US FDA has put a black box warning even for metoclopramide. And fenugreek, some of the side effects are flatulence and diarrhea and some amount of allergy, cross sensitivity between Fabaceae and Asteraceae family. And in domperidone, other, I think more significant even side effects which are more common are headaches and fatigue and tiredness, which a mother who doesn't need, she already is enough fatigued. If she doesn't need domperidone, please don't overtire her again. And there are some interactions. I think that slide is gone. So that slide I somehow missed. The interactions with metoclopramide we need to remember are antihistaminics and all CNS drugs, especially CNS depressants. And so MAO inhibitors, antidepressants, and then domperidone has significant interactions with all cytochrome 3A4 drugs. So they include all our antifungals. So antifungals we need to be really careful because some of the mothers are on them, and then even ritonavir and some drugs like protease inhibitors are there. I am not able to recollect now. So In fenugreek has interactions with hypoglycemic drugs. So diabetes mellitus, GDM mothers are especially prone for poor lactation, and we tend to give them galactogogues. We need to be mindful that sometimes they might be type 1 diabetes mothers also who are still using some medications, or she might be, a chronic diabetic who's using metformin. So just make sure that, and also blood thinners, their effects are also increased by fenugreek, not just garlic. So warfarin, heparin, all these effects are potentiated when the mother takes fenugreek. So let's be mindful of that. And so again, sir has covered this, but I just quickly go through that we need to understand low milk supply to understand why galactogogues are not the answer, but something else is. So there is lactogenesis 1 and 2, and we talked about how it becomes an autocrine response after the initial days. So I'd like to give this analogy of a car. Okay, all of us, how many of you drive cars? So the progesterone is our parking brake, wherein all the hormones are there during the pregnancy, but the parking brake is on. That is why the car is not moving. And then the lactogenesis stage 1. Stage 1 is all the endocrine hormones, is the ignition. So the ignition is required for the car to start, but it doesn't ensure that the car keeps moving. In order to ensure that the car keeps moving, you need to accelerate, and that is what the autocrine supply-demand thing is. So even if you ensure that the parking brake is down and you put the ignition, but you don't press on the accelerator, your car is going nowhere. You start again and again is what domperidone is doing. If you don't accelerate with proper breastfeeding interventions, your car is going nowhere. So yeah, oxytocin, we all know oxytocin. We need to be mindful that it is such a sensitive hormone and is extremely shy and is extremely social, and it's extremely dependent on the self-efficacy of the mother. If the mother thinks that she can do it, her confidence is going to potentiate her oxytocin. If there is doubt, if there is worry, if there is pain, it is going to harm her. So the NICU mothers who go up and down stairs 10 times a day, you give her domperidone, but you don't treat her episiotomy pain. You don't give her bed on the same floor. What is the point, sir? And you don't facilitate inter-mother interaction. You don't. These mothers stay with each other for such a long time. And in Nilofer, I am blessed to see that mothers are the ones who do all the nursing care. Our poverty is also our blessing in Nilofer, because mothers are there most of the time with the babies, and that ensures a better KMC. And I'll tell you that though they are there for weeks together, unless you initiate, you bring them all together, you sort of introduce them to each other and say that we are all in this together, and you take a group session, you take a group counseling, things improve so well, so fast, and they help each other and they become each other's lactation counselors. So we need to use oxytocin's social component, which I think we don't use enough. And like Sir said, feedback inhibitor of inhibition. So we need to understand it's not just the distension, it's also the amount of feedback inhibitor of lactation is a whey protein which is there in the milk. So the amount of milk that is residing will sort of send inhibitory signals to the brain saying that you don't produce more, we already have enough. So this, there is this important concept which I'd like to stress upon, which is the prolactin receptor theory, which sets this calibration phase. So we need to understand this, because whatever you do later, if this mother comes to you later on, it's not going to help so much. When she's there with you in the initial weeks, you need to ensure that her calibration goes well. So what this says is, frequent milk removal in the early weeks of postpartum increases the number of prolactin receptor sites. So this is something like insulin resistance in diabetes. I'll just explain that simile in a while. So more receptor sites will be stimulated by more frequent milk removal, and this makes sure that whatever prolactin is there in the later part of the postpartum will act well on the cells. If you later give prolactin, sir, with lot of domperidone and there are no receptors, it is not going to act on the cells, and domperidone is not going to save matters later. So we need to ensure that all the receptors possible are, seeded into the lactocytes as much as possible in the first few weeks of pregnancy. First few weeks postpartum. And this is critical because later if you even pump the mother with so much domperidone, all that prolactin will go where? So it's like diabetes wherein there is a lot of glucose everywhere, no glucose is going inside. Just because there are no, and there is a lot of insulin also everywhere, but the insulin is not acting on the cells. So a mother, postpartum mother who has lost this initial few weeks just because of our inadequacy, and she lands in a prolactin poor receptor state, is, will not be able to benefit from whatever you do later on much. Yeah. So the ultimate thing is drainage of breasts promote short-term and long-term milk supply. This is something we need to drill into our mothers' minds and into our teams' minds. That what you produce today is going to improve supply not just for tomorrow and day after tomorrow, but also for months and years to come. Years, I mean, if the mother wants to breastfeed, that will ensure the initial few weeks are going to ensure how long she'll be able to breastfeed later. So we need to keep in mind that there are some medical causes also. It's not just always, if the mother says that she has poor milk supply, we need to think why, simple measures like positioning and attachment are not able to help her. So she might be pregnant, she might be having a retained placenta, theca lutein cyst, she might be on OC pills. Many mothers, without knowing this, start contraception on their own, and unfortunately that affects their milk supply. If she has cold cough and she takes sinus 77, pseudoephedrine is going to lower her milk supply drastically. So we need to be mindful. Instead of using domperidone as a stop-all drug for stop your rant drug, you need to give attention to what the mother is saying, take history, dig into details, why things are getting worse, and solve the problem. So these are causes of delayed lactogenesis too, which we need to be mindful of. And delayed lactogenesis or medical intervention does not, medical causes of poor supply doesn't automatically mean that you have to give galactogogues. It means that you need to intervene more effectively, and this mother needs antenatal education even more stronger. So, okay, here's a question. What questions do you ask to assess the adequacy of milk in your OPD? Or when you meet the mother, how do you assess the adequacy of milk? Yeah. Anyone? No, not you. Anyone? Yeah, urine output, very good. Is the baby comfortable or crying? Sleeps after feeding. Growth, very good. Weight gain. So some of them are reliable. Urine, stool and weight are reliable factors. What is examined is the pressing nipples as soon as delivery and labeling the mother, this mother doesn't have milk. So we need to be mindful that our teams also have to be educated and know that, they should know what the signs of adequacy of milk are. And to demonstrate, so if you go to a bakery, it's, I forgot to say this. Most of the times, though we are saying this, there is a selection bias here because people who are interested in breastfeeding only have come and sat here. Usually what happens is to assess the breastfeeding adequacy, the doctor goes and asks, Amma paal saripotunaya? Amma paal saripotunaya? The answer will be ledu. Meer bakery kelli ee pastry fresh ena ante avunu ani antadu. So and I'm emphasizing this because the studies also show that, the perceptions of low milk supply are prevalent among women. It's not just your hospital, my hospital. All mothers think that they have inadequate supply. So in this study, about 3/4 of the mothers felt that they have inadequate milk supply. But then only half of them gave, many of them didn't give formula at all. And many of them continued to breastfeed, which shows that milk was adequate. And, this is a US-based study where there are a lot of lactation consultants. So 60% of the mothers had consulted a healthcare provider about not making enough milk. But then see, 50% of them were on galactogogues. 4% of them were on pharmacological, but then 46 non-pharmacological measures were also used. And So some of the perceptions mothers have are very unscientific. They think that milk is thin, or they go by just baby's unsettledness, and that there is no feeling of letdown. And anything automatically first thing the parents ask is, what should I feed this mother? What medicine should I give? So the thing is, we need to assess if there is a mother saying that she doesn't have enough milk supply. We need to go in this sequence without missing any step. First, listen to her, observe her. Like if a child comes with diarrhea, will you just give IV fluids? You will ask for history, you will ask for how many stools, you will see and decide how much dehydration, only then you will give IV fluids, right? Same for milk. And you measure, you observe, you assess the breastfeed, you understand what the psychosocial conditions of her are, and then only intervene. But the thing is, perinom sort of overclouds and overshadows everything else. As soon as the mother says low milk supply, we write down galactococcus. And the hierarchy of interventions is also very important. We need to establish trust and improve position and attachment and make it sustainable. You can't show just this position and leave it. The mother should be able to do it on her own when she goes back. And emptying the breast is very important. Pro-oxytocin is important. So the mantra I'd like to leave you with is, before you domperidone, do emperidone. Emperidone is ensure mouthful of breast, and kangaroo mother care. P is for positioning, pumping. E is for expression of milk, effective expression of milk. E is for empathy. R is for responsive feeding. I is for increasing feeds. And increasing milk transfer during feeds. There are many ways you can increase milk transfer during a feed. And D is for drip method, drop method, that is supplementation at the breast. So these should go before you go to domperidone. And optimizing oxytocin, NNS, nipple stimulation evaluation. Okay, so I'll just hurry up because, yeah. So my problem, the bane of galactococcus is not the galactococcus. It is the way we use them. We use them without indication, we use them without a diagnosis, and we use them as a first line of therapy, which it isn't. It's like, how would you feel if a child of dengue comes and you give inotropes first? Same for milk supply. So before fluid you won't give inotropes, and before correcting these you shouldn't give. And I have a problem with galactococcus being used in place of baby-friendly hospital steps. So because so much in loss of exclusive breastfeeding rate is because the systems are failing. It's not just because there is galactococcus deficiency in the mother. And you use in place of listening, use in place of assessment is a problem. The problem is many gynecologists and pediatricians think they're very pro breastfeeding, and they do things and they think I'm writing all these medications also, I'm very pro breastfeeding. And the mother also thinks I've been given a lot of help, but ultimately she fails and she puts all the failure blame on herself. Mothers tend to think that they have received all the help that they can, but still they have failed. But it is we who have failed. If this was you, this is Mark. Okay, this is the last slide, ma'am, I promise. Fill in the blank. Fever is not a sign of ceftriaxone deficiency. I don't have enough milk is not a sign of galactococcus deficiency. Yeah. So, ma'am, just one last thing. I know I'm taking your time. So, it's not just that galactococcus are not useful, it is also that they can be harmful. One, they prevent follow-up. And two, they can cause active oversupply issues. I'll just play this. You can see this is a term, Laddu child. See who's coughing, and this is just oversupply caused due to excess pumping and galactococcus being flushed into her system. So, and they can, if there is no enough drainage and you keep giving galactococcus, the mother is prone for engorgement. And an engorged breast, see, it's easy for the mother to learn how to latch the baby on a softer breast. Once the breast is engorged, the baby is not going to learn to latch very well. So you're potentiating the problem. And when you teach the mother how to express milk on a softer breast, it is easy. If the mother is engorged and now you try to teach her good hand expression, it is going to be very painful for her. So it is not just, we are actively causing problems. And foremilk syndrome, like ma'am said. And so over-engorged breasts and mastitis. This is a mother with plug duct, just because there was so much oversupply and it was not drained well. So, again, change the norm, shift to perinorm, which is this. Yeah. Okay. Okay, thank you for the opportunity.
So I would like to call Dr. Praveen and Dr. Sneha, both of you here. So we are going to ask some practical question which we are facing in our day-to-day life, and you are both going to say whether for and against it. So usually when somebody, usually in LSCs, post-cesarean section cases, on the first, second and third day, the milk secretion is very less. Usually we have observed that. And we encourage them, okay, you go ahead with breastfeeding. Already that counseling has been done by our lactation specialist, everything. But still it is not sufficient. And again the neonatalist or the pediatrician comes and tells the baby is not gaining, there is a loss of weight more than 10-15% and the milk is not sufficient. So what you would like to do on the second and third day when the baby doesn't gain weight? And when we examine the mother has the breast which is secreting milk but not that much sufficient. So whether, Dr. Sneha, whether you are going to give the galactogogues or not?
Ma'am, there was an RCT which tested only term LSCS mothers with galactogogues, Perinam specifically.
No, I am asking not about the RCT, practical.
My personal first would be to, ma'am, I don't think we do enough on the lactation side. I mean, the positioning, if you see, rarely are the babies put completely prone on the mother's chest. And
no, baby is losing weight and our lactation specialists are always going there and they are training them.
Skilled lactation care is different from just having a lactation professional. Till the time we are able to fill the gap of good education and, I completely agree that, just lactation counseling is not going to help everyone. But then for majority of the mothers, it does help. And when you say that the mother doesn't have enough milk, I disagree. Of course, there are some conditions that, if the mother has GDM and then that is why she is going for an LSCS. If she has some other condition, that is why she is prone for LSCS. If it is an elective, I agree.
Okay, Dr. Praveen, whether you like to start or what? Means maybe weight loss is there. More than 15%, if you say 10-15% or something. Start galactogogues or not on that. When you are seeing there is no breast milk, much sufficient breast milk on that. On the second and third day.
Can be done, ma'am. Egg breast supplementation can be done. Galactogogues.
Okay, fourth day, fifth day also baby has a loss of weight and mother is not able to.
But we have to rule out all other causes.
I am ruling out that breast milk is less.
And milk expression
is less, yeah. Everything has been done. I am ruling out that.
Latching, attachment.
Latch, attachment, everything is less.
Then we have to prescribe.
Which day you will advise?
There is no evidence, ma'am. Like there are some studies, most of them used after 5 days. Most of the studies. Yeah. But there is less evidence for early starting. Like within day 3, day 4. Less studies are there.
Yeah, in day 3 and day 4, still the weight gain is not there. And we have examined clinically by a gynecologist the breast and by the lactation specialist that the breast milk is not sufficient.
As soon as you see and you're sure that other things
are not done, then you can
start.
Okay. So that's the thing. So both what my conclusion is that that usually we should use this lactation specialist both prenatally also and educate them and also during the time of
There is a belief in mothers that they cannot feed in the first and second days, and after that the milk supply increases. It's a common belief for everyone. So how does a galactagogue act when we give it on the first day or right from the birth and tell the mother that this will and we feel that it may psychologically increase the breastfeed? Does it act in that way?
that useful.
Usually
But then placebo effect, I do agree, sir.
Usually galactose works in mostly in the preterm babies when 32-week delivery or something, that helps in the initial phase because that milk will not be sufficient for that baby. So that is there. But in term babies, usually on the second and third day, the milk comes. That is the normal thing.
So when galactogogues are given right from birth or since first day, because there is parental pressure and the grandparent, someone comes that she's not getting enough milk and they already know that what is the name of the galactogogue. So they only start giving or they might buy it from somewhere. And when there is poor latch, what is your experience regarding using galactogogue?
My experience, thank you for asking, sir. I've usually seen that before we come, they already are buying, they're already taking. And I've seen many times that, there is a very engorged breast. The baby is not able to latch, the baby is getting dehydrated, the mother is getting engorged, the baby is getting jaundice and fever and getting admitted. And a lot of times it is, the focus shifts from positioning and attachment to galactogogue. And then, like I said, the complaints of the breast become so less when it is so full of milk, and that makes the latch even more difficult, especially for a sleepy baby. So that actually makes things worse. So I think we need to use galactogogues, but in their right place. Yeah.
What we call is a judicial use of the galactogogues. That term.
No, actually, if we are using for placebo effect, galactogogues we are using, when we need to stop, because stopping of galactogogues again can cause the decrease in supply.
With respect to DOM, I actually also had this doubt if you start in a normal woman, does it affect any? But I couldn't find any literature. The recommendation for, if there is an indication you start, it is like once the milk supply is established and you have taken care of other things, you wait for a week or two, depending on how bad the situation was, and then you slowly taper. So you taper by, if you're using 30 mg per day, you taper by 10 mg every 5 to 7 days. And you check if there is a worsening of supply. If there is a worsening of supply, you can actually prolong. Placebo effect, I don't know.
Placebo effect, no galactogogues is only you can.
So as soon as, if most mothers stop, if you are able to see that the baby is gaining weight, stop it. If you know that things were not actually wrong before itself. I think that is.
Use the tablets for 5 to 28 days. 10% of the population use for 6 months also. There are records. So 28.
No, ma'am, they've been used for 6 months and prolonged also. And safety was established. But then, for relactation, even preterm also. But placebo, I don't.
From the judge
Included. Judicious use of galactogogues.
So I think that was a very close call, and both the speakers brought out the points strongly for and against their respective arguments. So certainly, as in most of the interventions in medicine, there is a place for galactogogues, but then it is not something that needs to be unleashed on every mother without due analysis of the factors that may be contributing to poor milk supply. So I heartily thank the debaters, Dr. Sneha and Dr. Praveen, for this very interesting session, and Dr. Jasmine Rath ma'am for being the moderator. So I request our team to kindly start the felicitations, and we will go on concurrently with the sessions. You can do it here on the backdrop of the logos of all the associations. So Dr. Rohini, can you please kindly felicitate? Ma'am, we'll invite Dr. Jasmine Rath ma'am first, Dr. Praveen, Dr. Sneha, and Dr. Pranitha for her talk on human milk banking. So once again, it is my duty to thank the sponsors for the day, Serum Institute. We have Mr. Mithun and Mr. Rajshekhar here representing the organization. Thank you for supporting this event. And a kind reminder for all the pediatricians and the obstetricians. We have now Indian-made powerful weapons for the prevention of pneumococcal infection, which is the commonest cause for pediatric pneumonia and pediatric infections, bloodstream infections, which is the 10-valent strain of pneumocid, which is conferring more than 70% immunogenicity for all the strains prevalent in India. And we also have Cervavac, the first Indian-made vaccination that protects against cervical cancers, including the 4 common strains of HPV. Thank you, Serum Institute, once again for your kind patronage of this event. Can we give them a good round of applause? Thank you, Mithun and Rajesh. So we'll now proceed with the next talk, for which I'll invite Dr. Shilpi Reddy, Clinical Director, Obstetrics, Gynecology and KIMS Cuddles. She is going to talk to us on something she is very passionate about and has authored lots of books and chapters on this, about the role of nutrition in pregnancy, the role of nutrition postpartum in optimizing breastfeeding. Over to you, ma'am.
Hello all, good evening, and it's an extra pleasure talking to all of you all. It's not only about delivering miracles of joy, it is also taking care of those miracles of joy post-delivery. So what moms need to do to establish good lactation? Is it baby-friendly hospital initiative or what? Because lactation is a complex phenomenon. It has a lot of cerebral component into it, physical effort into it, motivation by people around you, and there are several factors. It is not only about a mechanism of hormones, it is too complex to think about lactation in an individual perspective. What is prenatal education is something that has to be concentrated if you have to talk about lactation. Lactation, there are several people who influence a mother, saying that some say lactation is good, some say lactation is not good. Some say it is cosmetic friendly, some say it is cosmetically not friendly. Some elders say that you should lactate, some elders say you should not lactate. So prenatal education about the right methods, right concepts is very important. Not only about lactation, even about the kind of food that you need to take before pregnancy, during pregnancy and post-delivery also. So prenatal education about the right methods, right concepts of lactation has to be incorporated to a woman. Now in this hospital, we usually, 95% of women are educated, self-sufficient, working, and middle and upper middle class. So I would be talking more specifically about them rather than anybody else. So there are so many myths and there are so many truths about lactation. The myths have to be busted and the truths have to be educated. And every bit of a thing has to be told to them if they have any pre-notions on it. And there are several points to concentrate. Some of my points, that is, you have to give them informed choices. After delivery, you go to the mother and you tell her that, come on, let's start breastfeeding. I just finished off everything with you, then let's start breastfeeding. If she says, I don't want to breastfeed my baby, what are you going to do? What is the panel going to do? At that point in time, counsel her and tell her, no, breastfeeding is good, it's good for you, it's good for the baby. She might have her own nonsense in her brain. So, when you have prenatal education, you have to address to her choices. Some people are very particular. You give them hundreds of lectures, they will not listen to you. So, we have So it's about informed choices that you need to give her, and she should be able to decide what is good and what is bad and what is right and what is not right. And it's a doctor's duty and people around her to incorporate positive attitude. People who have negative attitude, I will not get milk, madam, I might not get milk, madam, my milk is not insufficient, my baby's weight gain is not good. Even though the baby's weight gain is good, they will have separate targets in their brain and think that this is not good, and they will start top feeding. So positive attitude is the cheapest thing that needs no drug, no medication, no food, nothing. It's positive attitude that gives lot of time solutions. And hardly did you see any mother having skin to skin contact these days with the baby? Either the mother-in-law is carrying, either the husband is carrying, either the attender is carrying, or everybody else who's coming to see the baby is carrying the baby, except for the mother. What is rooming in, what is skin-to-skin contact, you have to be very, very, very particular about it. Unless and until there is skin-to-skin contact, where from on this earth will the hormones work and the breast milk will come? It's a very simple concept, but we are still yet to explore that option and stop people, taking care of the baby. Even at home, mother is given rest, baby is carried by everybody else. Mother doesn't even take care of the baby, somebody else gives bath, somebody else changes the diaper, somebody else does every other thing. So how will she get breast milk? And the golden hour. It's very important within 1 hour to establish breastfeeding. That practice gives a lot of positive support, and at that 1 hour we can actually deviate the mother towards the baby and give her the latching techniques, give her the techniques to establish breastfeeding and all that, and we will have enough time to handle her suturing and everything, and she will be deviated in one way or the other, taking care of the baby, looking at the baby, handling the baby, seeing the baby, and giving a breast crawl and all that. And the mother should be encouraged to be with the baby constantly. This one point makes a lot of difference, and it is the niche to give good, breastfeeding relationship. Family support. The family has to be told in very, very clear terms that who has to do what and who has to take care of the baby. And anybody and everybody there have to talk positively and give her positive reassurances instead of spoiling her brain and giving her negative information. And another point that is very important is rest and sleep. Some kind of rest and sleep is very much important to have your hormones in place, not to have depression, not to have anxiety, to have that positiveness in a mother. She should be given adequate rest and sleep also. Hydration. How many mothers are hydrated? They look always dehydrated. It's a simple thing that every feed, before the feed you give 1 glass of water, and after feed another 1 glass or 2 glasses of water. That makes a lot of difference. Diet. Everybody socially also has their own, concepts about diet. Yes, some are friendly, some are not friendly, but you have to have the right direction. Prenatal time is the best time to explore about dietary options. Give them books that are actually having the right information about good prenatal diets and postnatal diets, the methods to cook them and easy methods to cook them and take them on a regular basis. This will help women even after delivery to establish good and healthy breastfeeding. Ancient techniques. There are several ancient techniques that work well for concepts of lactation and ongoing lactation. They have to be explored and taught during the prenatal classes. Here we have a very good system of prenatal classes where the neonatologist itself will have a class on breastfeeding and ongoing concepts of breastfeeding. We have a serious discussion about galactogogues. Something that is really lacking nowadays is privacy. The mother might want to have the private time with the baby. There are so many people around her. Privacy also encourages lot of rooming in, lot of skin-to-skin contact, and lot of positive assurance. Partner support is very, very important in such things. Giving her privacy, encouraging her to feed the baby, doing the other chores that is necessary for her comfort and her time to be spent with the baby is very important. If she is having postpartum depression, they will refuse to feed. they will refuse to see the baby, they will refuse to handle the baby, or whenever the baby is in her hands, they start crying. If such a situation is there, they have to be under therapy and given adequate care. Help with lactation support, not only before pregnancy, before delivery, not only after delivery, during the process of labor also, the doula or the specialist who is attending to the delivery should talk to her about 1 or 2 points about lactation. Now the baby will deliver and we will start the lactation. And even during prenatal classes, it's important to establish a rapport about healthy lactation techniques. Education, 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 and the right education is very, very important. Definitely, you should bust all the myths that they carry in their brain. Ask for a question answer round where they have their own questions during prenatal classes. We ask them, do you have any questions? Do you have any myths? Let us talk about those. Avoid depending on formula. This formula is one devil. It is a double-edged sword. If it is required, it is very good and it's too beneficial. But if given unrequired, it's again double-edged sword, cutting down on the ongoing process of lactation. Nighttime feeding is very, very important. Why we look into nighttime feeding is again the response of hormones and their impact on the breastfeeding pattern. Teats and pacifiers they work against the breastfeeding mechanisms, and always they are hampering the adequate response to breastfeeding. There are several support groups wherein if you can join your pregnant woman in those support groups, like we have our own Cuddles prenatal and postnatal groups where everybody is encouraging about such things in terms of promoting breastfeeding, enhancing breastfeeding, foods that enhance breastfeeding, what are the lifestyle measures that do enhance breastfeeding. So these kinds of support groups that help, they're like ancillary care to consultants, they actually work. And encourage express breast milk in special situations like preterm delivery or in situations when there is a little difficulty. Nipple preparation, we actually focus more on nipple preparation during pregnancy itself. So once the NT scan is done, we always have 1 or 2 lines that we tell them that nipple should not be inverted, nipple should not be flat, make sure nipples are not cracked and they are not left like that. Sometimes we also give them nip care ointment to be regularly applying and just pulling the nipple outside so that you will not have flat and inverted nipples at the time of labor and delivery and after delivery. So some specific time you have to allocate to talk about this, and we have a written prescription for that so that we finish that talking even before it is too late. And nipple preparation most of the time is not happening because they are not interested or they don't know about it, and that is one of the cause of delayed lactation, delayed latching and failure. Role of vitamins is very, very important, and I will talk about them. Support groups, peer counselors, nurses, lactation consultants, labor support, physicians, groups of hospitals like what we have, prenatal and postnatal groups, in the home, in the clinic or community. Every place should not be left to promote lactation because that's the best way to nourish the baby, and also it's the best way for the mother, for her health also. Maternity leave. The exclusive maternity leave of 6 months is only and only post-delivery and for the baby, and exclusively for the mother and the child together to have 6 months of exclusive breastfeeding. Nowadays, once they are pregnant, 6th month or 7th month, they want to go on maternity leave, and once after delivery, they want to extend, they'll extend, otherwise they'll put the baby on formula and just go to office. So maternity leave is not for pregnancy, it is for post-delivery, and I do not encourage pregnant women, if otherwise there is any other need, to be on any leave before delivery. So their last day of working is before coming to the labor room. And after delivery, 6 months exclusive breastfeeding has to be promoted along with the government initiative of giving 6 months exclusive uninterrupted breastfeeding leave. Foods that actually promote breastfeeding are healthy foods. Basically, these foods have to be incorporated in their life before even they are pregnant or during pregnancy, so that the ongoing rate of having healthy foods is there post-delivery also. So simple, whole grains, oats, barley, protein-rich foods. If there are non-vegetarian, chicken, tofu. If there are vegetarians, legumes, lentils, chickpeas, leafy vegetables, fennel, nuts, sprouts, none of them are, out of the world. They are there, they are available in this region, and they can easily be incorporated even before getting pregnant, during pregnancy and post-delivery also. Because they are rich of protein and minerals, vitamins and everything. And foods that promote breastfeeding, again, we have traditional foods that promote breastfeeding like garlic, ginger, fenugreek, sesame seeds, fox seeds, brewer's yeast, molasses, almonds and papaya. Any combinations of these will work well for pregnant women, and we give a list of food items that actually they can have on a regular basis post-delivery. And energy-rich foods. If the mother is constantly tired, she's not eating food properly because constant attending the baby and she's not eating food properly, she'll be drained out, she'll be dehydrated, she'll be malnourished. So there are some instances where we should actually promote healthy foods on a regular basis to her, give her a schedule when you should incorporate fruit, how many vegetables she should eat, how whole grains have to be incorporated. Just get them out of maida and maida and maida. I understand that bread has yeast, bread has some component of, the yeast that promotes breastfeeding, but maida is again too toxic. It gives a lot of weight gain, and 80% of the mothers here are diabetic during pregnancy. We just can't give bread to them. So always whole grains, sometimes brown rice, protein, egg and yogurt, fats, healthy fats, especially coming from the nuts, coming from the ghee and butter, which are not avoided, and DHA, and special, they're very, very important for your brain, eye, behavior and mental health. DHA is something that is very, very important for all the 4 functions. So energy-rich foods, they're building blocks, or the DHA is the building blocks for these 4 areas of development, and you can incorporate fish, eggs, berries, seaweed, Brussels sprouts, spinach, cauliflower. Most of them are available here. Fruits like mangoes, muskmelon, berries, avocados, these are all having DHA. So these are actually DHA-rich foods. Both vegetarian and non-vegetarian options are there. And chia seeds, fox seeds, hemp seeds, edamame, kidney beans, nuts like walnuts and cashews have a lot of DHA. So DHA, again, as I have told that, it has a lot of effect on brain, eye, behavior and mental health. So DHA-rich foods are also promoted during lactation. They also are very helpful for the mother and the baby in terms of improving quality of milk. And it's a misnomer that DHA is only there in non-vegetarian foods. There is a rich source of DHA even in vegetarian sources. And here at Cuddles, we have a partner in line who actually provides us postnatal foods which are rich in traditional outputs of enhancing lactational support and also recovery of the mother together given. So basically Nuska Kitchen is from Jaipur, and we have these products in our counter which actually promote good protein-rich foods along with the natural galactogogues and repair mechanism that is available to their disposal after the delivery, during pregnancy also. And the problems of the post-delivery time because of stress and lifestyle, they have a lot of problems, and baby's health again totally depends on breastfeeding for the first 6 months. We are promoting these concepts of foods both for the recovery of the mother, for the traditional advantages that it has, and the weather that has to be taken care during post-delivery, and it suits Indian weather conditions. So small things like ajwain, small things like haldi laddu, and small things like gondka laddu and panchmul, all these things have traditional advantages and we give them on a regular basis. And there are small solutions to the root of problems that we address, and we have our own system, Indian traditional systems that are there in the Charaka Samhita and other Ayurvedic scriptures that actually promote certain foods post-delivery. Now the Western world is behind our Indian literature and we are still quoting the Western statistics. But when we talk about our Indian literature, our own Indian Ayurvedic literature has certain amount of foods that actually promote lactation, actually promote well-being, wellness, repair mechanism, weight management, and strength of the postnatal mothers, enhancing lactation, nutrition and proper recovery. And we have products that actually are homemade traditionally with a certain amount of protein rich, no carbs, only complex carbs in them, so that they are friendly even for the normal mothers, diabetic mothers, obese mothers. Everybody can take this and without any side effects. And we have a lot of solutions to every need and every mother in need, and both prenatal and postnatal foods are available. Lactation promoting foods like satavari, ajwain, sont, gond, methi, jeera, makhana, kaju, ragi and many more in combinations that enhance the lactation and also the strength during pregnancy and post-delivery. We in fact have seen a lot of increase in normal delivery rates when we take these supplements during pregnancy, because they are not eating junk instead of these. And when they take these, their body mechanism is good, their strength is good. Simple items like ragi, how good they are to Indian women, it helps them a lot. And it helps in improving naturally the lactation mechanism and the recovery postpartum. Improves the nutrition level of the body, and for both baby and mother, culturally viable and made per traditional recipe of Charaka Samhita. And when we tell them what is there in these laddus, the actual family members who are there in the family, the elders, they relate to their mother-in-law and their mother-in-law, making those and giving them in the house in the previous days. So not only tastes good, it is easy to consume, and the generation of mothers now with less putting effort on making them, they can have these instead of the medication that we give as galactogogues. And it's all about what amazing things everybody wants to make them happen. It's always with good intentions, and with that intention you should always go and make things happen in the most miraculous way for positive pregnancies, outcomes and good lactation, because lactation is such an important term in woman's life. It is so good if you promote it, and if the woman, if she is pro-lactation, she will also have a lot of benefits for herself and the baby. Actual baby admission rates to the, any hospital are very low in lactation, when the lactation is ongoing. I can tell you my own example. When my children were born at 26 weeks, I gave them 1 year, twins, 1 year complete express breast milk. Because I was working, I used to express breast milk. I have never had any deficiency. My kids never went to the hospital till date except for some small constipation issue or some, other little issues. They never in the postnatal period went to any hospital with any kind of an infection or anything like that. It happens very efficiently when you work towards establishing a bond between the mother and the child. First, my twins I gave lactation for about 1 year, and my second child I breastfed for 2.5 years without any interruption. There will be several people telling you so many things. How long will you give? How much more you will give? Nothing. You should not listen to anybody. You are the mother and your baby is your responsibility. Positive attitude and positive thinking is very, very important. And this is a very subtle subject, and we should definitely promote together lactation and child and mother well-being together. Thank you. So we have, I have 2 books that I have written for pregnant mothers, and also a book for PCOD and infertility. So anybody with PCOD and infertility, we hand over that book and they take care of themselves. With that book management, it has got yoga, exercises, food, recipes, all combinations and everything in it, and tips like intermittent fasting and seed cycling and all that in the PCOD book, which we give for PCOD mothers and infertility, and 1 book I've written for pregnant mothers, and that can be continued for post-delivery also, with all recipes and easy on-access foods that everybody can make, including the husband in the house. So it's so easy to handle, and my practice has become much more easier. And again, I have products from Nushka Kitchen that we actually promote during pregnancy and post-delivery. First, second and third trimester is different, and post-delivery foods are different. I have a little lesser headache nowadays with lactation and everything. Anybody who's just gate crashed for a delivery or anybody, they are being taken care of our experts, and Dr. Aparna is also very particular about breastfeeding and all that. And we have foods in-house that actually are compliant with the norms of pregnancy, whether it is diabetes or whether it is obesity. We deal mostly with diabetic and obese mothers. We have millets in the house and all different combinations of millets which we actually promote. And it's very important to incorporate healthy living into families nowadays, so that we'll have lesser of problems, more of health incorporated, and we have 9 months to change them. It's not just any time period. 9 months we can actually change the world. So that's it. I believe in that concept, and we constantly tell them, nag them and be behind them. They will definitely change. Thank you.
Thank you very much, ma'am. And as you all would have appreciated, Dr. Shilpi is not just a clinician. She is an exponent of lifestyle modification, spirituality, health, nutrition. So patients come to her not only for the delivery, but for an all-round experience in all these different facets. We are very glad that we are joined by the team from the IAP Twin Cities branch. We have Dr. Lakshman sir, President of IAP Twin Cities branch, Dr. RSP Sri Krishna, Treasurer, and we have Dr. Pavan Kumar, who is EB member and ex-secretary of Telangana State Pediatric Academy. So thank you all of you, sir, for taking out your time. I know today is the inauguration of a lot of events for the World Breastfeeding Week, and they have rushed from one of those events just to join our event. Thank you so much, sir. May I now request Dr. Lakshman sir, who was actually supposed to chair this session, to kindly speak a few words to us. Following this, dear participants, we will not hold you for long. We have a panel discussion, which I believe will be the most practically useful session for all of us. And to do this panel, we have Dr. Shivaranjani Santosh ma'am. She needs no introduction. You all know her. A breastfeeding fanatic and a very gentle, compassionate pediatric practitioner by profession. She'll be moderating the panel. So we will begin after Lakshman sir's talk. So over to you, sir.
Thank you, Dr. Aparna, for inviting me. And to begin with, my apologies. We were held up with Nilofer Hospital for inaugural function for this breastfeeding week, and I joined in the tail end of Dr. Shilpi's speech. She has enumerated very well the role of homemade preparations and role of DHA, role of vitamin D, and all things. And it was a lucid presentation from her side, and we all follow and think. And on behalf of IAP TCB, I expect all the obstetricians and pediatricians to observe this August 1st to 7th as a World Feeding Week, and put up those posters and spend some time to how to breastfeed, what are the issues, what are the techniques, what are the hurdles they are having in providing breast milk, and what are the importance of the breast milk to improve the immunity and growth of the child. And on this occasion of World Breastfeeding Week, let us inspire every mother to breastfeed her child, as that is the most prestigious gift a mom can give to a child. Thank you.
I quickly welcome the office bearers of IAP TCB. We would be glad to felicitate Dr. Lakshman sir, Dr. RSP Sri Krishna, Dr. Pavan with a small token of our appreciation. So please join us, sir. So I know we are at the fag end of the day, but please do stay back for this last session, which is going to be a panel discussion on practical challenges in breastfeeding. And for moderating this panel, we have none other than Dr. Shivaranjani Santosh, a very respected senior pediatrician. And as I just told you, someone who has one of the highest successful exclusive breastfeeding rates among her own patients. There can be nobody else more befitting than her to chair this panel. Over to you, ma'am.
Just one minute. We would like to, on behalf of TCP, we would like to hand over this posters to you. No, one photo. This is okay, and then later.
Aparna, one question each or two? One, huh? Okay.
We can have two additional questions, all four panelists.
Okay, done. Dr. Sri Krishna, Dr. Vijaya Krishna, Dr. Aparna and Dr. Shravanti. Yeah, please have a seat. We were supposed to give 3 questions each, but I'll wrap up with 1 question each and maybe another 2 questions for everyone here. Aparna, slides have who is changing the slides? Okay, the first question is to Dr. Sri Krishna. So the first case is, this is a neonate 4 days of age. Dr. Sri Krishna, this is for you. This is a neonate 4 days of age, has come for his first well newborn visit. Born at 38 weeks via spontaneous vaginal delivery, latched well in the first hour of life, no problems breastfeeding in the hospital, discharged at 28 hours of life with weight loss of 4%, term baby. Mom is a G2P2 who breastfed other child for 2 years. Today's weight, that is after 4 days of life, is 8% down from the birth weight. Resident working with you says, mom is feeding baby every 2 to 3 hours and feels it's going well. How would you proceed?
Yeah, thank you KIMS team, thank you NNF Telangana State Chapter for the invite. It's always a pleasure to come back to KIMS and to be amongst discussion on breastfeeding. This is a very common scenario that we face, and there are some very important points. This is a mother who is very healthy and a term child who has no birth issues, no real risk factors. Let us look at the baby as a whole. Don't just keep looking at that 8% all the time. Look at whether the mother is able to breastfeed as soon as possible, if there are any risk factors. And some important points that the mother has already breastfed in the past and she knows the importance of breastfeeding as well. Now this baby's weight loss is 8% down from the birth weight, which is 90 hours old. Now we'll have to look at what are the probable causes, but before that, are we looking at excessive weight loss or is it in sync with the overall weight loss that we expect? Now adequacy of breastfeeding, we all know it's a very complex thing, and mothers keep asking us, how do you judge something that you can't see? If it were to be measured, it's easier. But then these are scenarios where what the baby is taking is not visible. So you judge adequacy of the feeds only based upon the weight gain, the urinary output, and how the baby is after the breastfeeding is over. So looking at these factors is probably as important as just looking at the weight alone. So the 8% down from birth weight, yes, it's a concern, but you will have to look at the overall, the child. Please don't look at only the weight. If the mother's feeding is, breast is full and she has adequate knowledge about breastfeeding and is very confident that she is able to breastfeed her child, probably these are very important points to consider when we evaluate this baby. What I would rather do, and a very practical one, is to relook this baby after a couple of hours. I do not want to immediately judge anything right now, but yes, we do note down the percentage decrease from the birth weight, but continue to monitor. What I would do perhaps is ask the gynecologist if there are any concerns in the antenatal period, ask our lactation nurse or even our nurse to have a look, sit with the mother and assess whether the feeding technique and the perception of the mother is right or not. These are probably the first things before I ask Aparna or anyone else to look into it. I'm sorry, probably this is a very practitioner-oriented understanding of the problem, because I'm not looking at just one sentence, I'm looking at the whole baby as a whole.
But my question is, actually, do we need to really be concerned about the 8% loss at 90 days?
No.
I don't think so.
Yeah, no. And I think the no comes from looking at all of this.
Yes.
And that's the reason I said don't look at numbers, look at the baby. And if you feel the baby is good, mother has adequate knowledge and you're confident that the mother would understand what the scenario and what comes ahead, then I think the rest of it could be there.
Yeah, follow-up is important. Okay. The next question is to Dr. Vijaya Krishnan. Mrs. X is here with her baby for his 6 weeks vaccination. She's still breastfeeding, but had to start giving some formula because she wasn't making enough milk. Beginning 2 weeks ago, he became very fussy and didn't seem satisfied with the mother's milk. Now he seems to prefer the bottle, and she doesn't think she'll be able to keep up breastfeeding when she returns to work the following month. What went wrong, Dr. Vijaya?
So first thing is that this is her maternal perception. I think we have talked about it before in the course of the day today. Maternal perceptions of insufficient milk supply are probably one of the most common reasons for putting the baby on the formula, right? So this is at the 6-week mark. Oftentimes, Dr. Christina Smiley, who is one of the pediatricians and IBCLCs, who talks about what are the 7 hardwired things that the baby needs to breastfeed. One of the things she talks about is that sometimes the mom starts off great, and then there is in between the 6 weeks there might be a sort of a hurdle. Sometimes that hurdle comes at 6 weeks. It might be that also, but it most likely is related to her perception, and enough research shows us that perception of insufficient milk supply seems to be the tipping point for the mom to go towards formula, right? As far as the weight of the baby is concerned, the chart was there. The growth chart showed that from 5% the baby came to 50%, something like 50%, 50th centile. So it was not the weight that was a problem over here. So that also is kind of taken off. And then if we can go back to the original file. So the point where she started the formula, that would be the time when the baby probably had that faster flow and suddenly started not wanting to go back to the mom's breast, which then lands the mom, making the mom and feel that she does not have enough breast milk. Finally, as she's going back to work, that was the other thing that was put up there, that finally going back to work might be one of those thoughts that she might be having as to how do I continue this. So I think it's not just one factor, but multiple factors. But from the baby's side, again, and from the mom's side, it is definitely not lack of milk that is causing a problem. It's more of sitting with the mom, understanding the layers of what has happened, and perhaps counseling her as to seeing where we could help her, and in understanding that A, her milk is sufficient, and B, if she has other issues, probably try to work with her to make sure that she has an ability to feed her baby as much as she wants over the course of the next several months.
Do you think it may be... Okay.
Yeah, let her finish.
Do you think it may be that, baby is going through a colicky phase and just seeking out the nipple for pacification, and mother assumed that she has insufficient supply and so started formula?
That could be
one
it.
possibility.
Yeah.
And the other thing is, what would you do about the nipple confusion?
What would I do?
Nipple confusion.
Nipple confusion. So that's the other thing too. So once you start on the bottle, then we have to talk to the mom and understand what her needs are. So if she is saying that she wants to, continue to have the baby fed with the bottle, then we have to look at that aspect. But if she wants to directly breastfeed, then we have to look at how we get the baby.
She has to go for work.
She has to go for work, yeah. But again, that at 6 months, at 6 weeks or 6 weeks of age, then we would be looking at sitting with her and assessing what her priorities are, who is going to be the caretaker for the child, and then assess what else we can do to help her with her own goals. I think at this point I'm looking at what her goals are and how she is going. It's not, so to me, I think there are two separate aspects. The first aspect is she having insufficient milk supply? And to iron that out and say it's not insufficient, but here are the other factors that you're facing, and how can we help you into, achieve your own goal? And last thing, I think I forgot to say this, at six weeks, there is also a growth spurt. So the baby probably went through a growth spurt, which again made this perception of insufficient milk supply very much possible.
Yeah, just because the last point was what went wrong. I find 3 things wrong here. One, the fact that she had to start. I think our health system should be strong enough to address. These are crisis moments. And if we do not have a mechanism where the mother seeks out for information and advice and then just gives in, I think we are going wrong somewhere. I think at the time of discharge, each mother should know whom to contact when you face this scenario. And it is always good when you tell the mother you will face this. And they usually do it at around 2.5, 3 months. We all know that. So you should tell the mother that you might face this. Do ABC. It could be reaching out to somebody, writing an email, or coming down and visiting the hospital. Spending these 5 minutes is very valuable, because once that had to happens, you can't revert so easily. The second, what went wrong is, we're not talking about he became very fussy. See, it is very nice, idealistic for us sitting on this side and saying give, give, give. But then once the mother goes back home, this kid is fussy all the time, and the mother is deprived of rest. You see those mothers after 48 hours, you will realize that what they are asking you is just a little sleep, a little rest. These are very important moments. You keep only talking about theoretical part and you do not address why he is fussy or what she can do when he is fussy. You will never solve the problem. All that you have said will be heard by her. She'll go home, and then for all of us, nothing more valuable than sleep and rest. So you will eventually give in. The third one, which is probably beyond our control, who asked her to get back to work next month? She returns to work in what? 2.5, 3.5 months. This is wrong. 6 months is now the government's mandate of maternity benefits. Agreed. That is why I said that is wrong. Now who has to make it right? That's why in the beginning I said it is out of our purview. So what went wrong? Her pressure of going back to work. I think these are all things that we should address, and these are all elephants in the house. We can't just shy away from it. There needs to be some action on it, but at least the first 2 things are in our hand. Please address the concern of the mother. If the baby is fussy, solve it. Second, please tell her what to do and tell her this problem will come at 3 months. Again at 5 months also this problem will come. Then you should have a plan so that she can reach out.
So ask the mother to sleep whenever the baby is sleeping, first rule. second, this is like colicky phase basically. So baby will keep on seeking out the nipple, being fussy, spit up and all that. So if baby is drinking milk comfortably at the breast, then fine. Otherwise, ask her to, burp, check if there's any other discomfort, address that discomfort, understimulate the baby, be soothing. Okay, and make sure there's no nipple confusion that develops. So now that is the major problem that she will need to address again. So if baby doesn't latch on to her, she'll all the more go into one kind of depression. So before starting bottle, at least start with the spoon wala or palada uggu ginna, or you get nowadays natural flow nipple bottles. So she can express her milk and use that bottle to give. So we have to give all the options and ask mother what she wants exactly and make a plan so that she sustains her breastfeeding as long as she wants to.
I just want to add one more thing. I definitely agree with Dr. Sri Krishna that there is a lot that we can do with initial counseling itself. Yes. So talking about the growth spurt at 2 days and 3 days, what is going to happen at 4th day, at 7th day, at 6 months, 6 weeks, 6 months, I think it's really important. The second thing is, I think we have to talk about the other white elephant in the room, which is infantilizing mothers and believing that birth and breastfeeding are required interventions, right? Like, so I feel like once we have gone down that path where the mom's already feeling that everything related to birth, breastfeeding needs an intervention from somebody and that she doesn't know best. I think we have already sort of put her in a space where she's always going to look for additional support, and the grandparents, like we talked about, everybody in society telling her that, maybe you don't have enough breast milk, start off something. I think that's the other thing. And last but not the least, I would say, I think the main thing that I feel is they don't know how much you care until they know you care about them. I think if you're able to tell them that we care about you, come back to us anytime you want. Our phones are open. These are our contact points. I think that makes a huge amount of difference.
So build up trust. Yeah. Okay, next.
That's the same thing I want to stress upon. One is while we send them back, at least we should have the confidence of mother that she can talk to us at any point during the first few weeks at least. And close follow-up during the first month will give excellent results of breastfeeding. Over the time, I have seen calling them at 48 hours, 15 days, 30 days and 6 weeks. So I think that kind of follow-up has helped me make mothers continue breastfeeding for long, exclusive breastfeeding.
So that investment we make is going to have a lifelong effect both on the mother and for the baby. So just spending extra few minutes to help the mother is going to go a long way.
The one who wanted to return to hospital, work faster might be a pediatrician mother or doctor or a busy practitioner. Thank you.
Okay.
But still, she needs sleep. We'll find a way out for it.
No, what we say is sleep whenever baby sleeps.
Yes.
You have to sleep, that's all. A 21-year-old primary, this is for Dr. Shravanti. A 21-year-old primary gravida mother delivered twin babies in your hospital, doctor. She started feeding the babies within 1 hour after birth. She was breastfeeding both the babies. After 12 hours, mother notices blood staining of both the babies' lips when she fed them. When she tried to express the milk, there was bloody discharge from both breasts. On evaluation, mother did not have any pain or swelling of the breast. There was no history of trauma to the breast. There was no lump in the breast. Examination of the breast did not reveal any tenderness, engorgement or mass lesion. Both the nipples were normal, no cracks or fissures were noticed.
After evaluating all these injuries, all that, directly we can go for the discussion of respiratory pipe syndrome. So, I think...
maybe some of of us here do not know.
No, there's rusty pipe syndrome. This is one of the normal variant, we can say. This is because of the engorgement of the breast. There will be epithelial damage, so that some bloody discharge which will be mixed with the milk. But it is not at all harmful. You can feed that counseling you can give, that you can feed the babies. But if you are not comfortable, then you can take the again counseling. You have to see the baby is able to take it or not. Baby is puking or what. That is the thing we have to see. And it will be cleared not more than 24 to 48 hours. That need not be an issue. And of course, as you said already, you have to check for the nipple cracks, any injuries or everything you have to check before going into that. If everything is cleared, then directly we can go for that. And nowadays these educated mothers, they are going into the Google and Googling it is blood discharge is a cancer. First the question they will come that I have cancer first of all. So that fear, how we'll remove is we can ask the breast, whatever the secretions for the examination also, for the just secretion. So to give counseling. Not necessary. That is only for a placebo, that is like counseling part. So to give some proof, because now the culprit is Google, so first they will think of cancer only. So all the family members, even 20-30 members will come repeatedly for the counseling. First husband will come, mother-in-law come, then distant relatives will come and neighbors will come, everybody will come. So that is only counseling part here, nothing to worry. And one more thing is like that fear of blood, like that they will think that the bloody discharge will harm the baby. The first that you should give counseling, that nothing will happen. You can give that the colostrum will be mixed with that.
Baby can have some spit-ups, that
Yes.
can happen.
Yes.
Anything else can color the milk red?
Any food color, food colors also sometimes. So that also we have to sing. That also, yes.
Examine thoroughly.
Yes.
Okay. Thanks. Thanks, doctor. This is again for Dr. Vijaya. This is as per their choices. It's not that I'm neglecting Dr. Aparna here. Okay. A 15-day boy of 15 days of age presented with poor sucking and difficulty in breastfeeding since birth. It took a longer time to complete his feed compared to previous siblings. Mum also had painful and cracked nipple with a pain score of 8/10. On examination, the infant was jaundiced. His weight was 2.5 kg. Breastfeeding observation showed that he had poor attachment and would come off the breast easily. Intraoral examination showed ankylosing. Other systemic examinations were unremarkable. What would be the best thing to do?
So first thing is we don't have the baby's birth weight, so we are assuming that 2.5 kgs is presenting with a significant weight loss. The mom has previously fed another sibling, so she knows how breastfeeding was meant to be. So this ankylosing often presents as either on the mom or on the baby's side or both sides, problems on both sides, the mother and the baby. Dyad, both have to be assessed. In this case, there is the picture itself shows that there is a classic anterior tongue tie, there is the heart-shaped tongue as the baby tries to extend the tongue. So that part we have sort of, examined and understood. The other thing to be looking at this point would be to see how is mom's milk supply, because oftentimes not only does it lead to pain for the mother, but it also leads to decreased milk supply because of inefficient milk removal. So if we directly say to the mom that, your baby needs a pranectomy, that may not necessarily work in their favor, because the milk supply, unless it starts to get built up, that may not essentially immediately, take care of the problem. Also on the other side, for the baby, if there is a significant weight loss, we need to do something for that at first. So perhaps a first point of, working with the mom would be to say, can we do express breast milk? And can we feed the baby first with whatever, cup or however she wants to feed? And then get the baby's side of this thriving up become a bit better. And then talk to the mom about the procedure, as in a procedure, and see if that would be something something that would be conducive for them. Having said that, not all tongue ties need to be, a frenulectomy needs to be done. I think oftentimes we forget what is the function. Is the function good? So have we doing a good functional assessment of suck, making sure that the babies, there are many ways to assess, obviously not just the structure but the function. So once we do that, and if both the functional assessment says that this baby is not removing the milk, and if the mom is consistently having problems with, whether it's just the burning, whether it is later on, as it goes forward, sometimes she may not have the immediate problems, but she might have post breastfeed later, like a longer time, she might have burning and difficulty in terms of the pain control. She might also have mastitis, repeated mastitis sometimes we have to look at for the oral problems. Literature says that anywhere between 1 to 10% have some kind of ankylosing, but it is one of the most commonly missed things as well. So I think from both sides, it should not be overdiagnosed and a therapy offered immediately in terms with a surgical treatment, but it should also not be underdiagnosed and said, oh, this is just a latch, this is just a positioning and that type of thing. Lastly, if we do offer the baby a frenectomy procedure, then everything, pros and cons, have to be explained, obviously. And finally, I think pre-work and post-work. These babies are the ones who are extremely tight because they are using their tongue along with every other part of the body. It becomes tighter for them. Oftentimes we will see tight fists and shoulders that are tight. So offering body work, teaching the parent-infant massages, talking to them about the work that has to happen post-frenectomy, because the pre and the post work is really the most important part of getting a good function out of the frenectomy and not just the procedure itself.
So function is what we have to assess and then proceed accordingly. What's your take on recent increase in lip frenotomies? It's going crazy. It's really unpleasant and unfortunate, but I think it's being overdiagnosed. I myself have helped so many moms, like they were referred for lip tie. They were sitting outside, they saw me, okay, doctor, can you just check? And everything went fine. Just needed to spend half an hour with the mother.
Yeah, I think it's very, very important because that part...
Don't overdiagnose things and offer a surgical procedure. First assess function, take some time, spend some time.
Absolutely. Absolutely.
Yeah. This is for you, Aparna. Baby 1 month of age, birth weight 2.4 kg, born to primary mother, was brought to the clinic by his parents. His mother complained that the baby was unable to feed milk. There was nasal discharge throughout, and he was unable to take oral feed. Feeding was only through Ryle's tube since birth, no other relevant medical record, let's say GE tube. On intraoral examination, unilateral cleft involving the lip, alveolus, hard palate, soft palate, uvula was seen. What are the different available options for optimizing breastfeeding?
So obviously this baby being tube fed for a month is pretty unfortunate. There are so many other options for optimizing oral feeding that could have been done. Now in cleft palate and lip, we know that there is a whole spectrum of anatomy starting from small clefts. So particularly clefts which are small, anteriorly placed. There are babies who would be able to establish successful breastfeeding. We have worked with some of these babies where we have been able to optimize breastfeeding because these are all small clefts which we would be able to close off fairly with the breast tissue itself, and the baby would be able to generate optimal negative pressure or suction that is required for optimizing for breastfeeding. This, however, may not be possible in the larger clefts, particularly in through and through clefts like something similar to what this baby is apparently having. These are probably babies that may genuinely require additional help because they may not be simply able to generate that degree of negative pressure that is required for sucking milk or removing milk, transferring milk from the breast into the baby's mouth. Now, as I already discussed, if it's a small cleft, not only do certain positions help. For example, straddle position is something that is found to be helpful, where the baby is placed in a sitting kind of position in order to prevent reflux, which is an associated issue, to prevent nasal regurgitation, and either with the thumb, the index finger or the thumb of the mum, or by squeezing the breast tissue itself, we may be able to occlude a part of the cleft, and thereby help the baby take direct breastfeeding directly from the breast. When this is not possible in large clefts, we may have to think of other techniques. Now, Rice tube is just a transitional phase until we kind of find the right technique. There are special needs feeder, Haberman feeders that are available from most of the companies that have feeding accessories these days. These are specially designed nipples which come with a long kind of teat, and there is also a valve which regulates the flow of milk. And these have been used for successfully establishing express breast milk feeding in babies with cleft lip. So special needs feeder or Haberman feeder is one of the techniques for oral feeding. Now, if we seek out help of experts like the maxillofacial experts, the dental experts, they may sometimes suggest an obturator which can be used for closing the cleft. But in our little experience, we have seen that these are not generally preferred by the plastic surgeons or pediatric surgeons, because these tend to interfere with the anatomy of the palatine ridges subsequently and may make subsequent repair of the cleft pretty difficult. There may be evidence to say that the use of obturators is becoming lesser and lesser these days, and wherever in situations where breastfeeding with a straddling technique or with a with the regular kind of support or by occluding the cleft is not possible, one may resort to a special needs feeder, which is generally more gentle on the anatomy. However, it is definitely true that it is possible to 100% do exclusive breast milk feeding in all these babies. One should definitely be very, very careful in trying to motivate mothers to start early expression, because very often when we do not give them this information, they may simply resort to formula feeding. It is also possible to give express breast milk feeding with a palada, which may be with having a long kind of teat, and wherein it may be possible to directly deliver milk into the posterior part of the pharynx.
Thank you. So 1, 2, 3, 4, 5. Last question for the day. Baby of Mrs. Y. Anyone can answer. Term female, LSCS, birth weight 2.8 kg, brought to the OPD on day 7 of life with complaints of frequent regurgitation, poor weight gain, feeding intolerance, and weight loss of 12%. How would we proceed? Anybody from the audience?
Look for any upper GI malformations, ma'am.
Malformations. Anybody else?
Upper GI tract.
Okay. Aparna, would you take the question?
Yeah.
Because you wanted to take that question.
So maybe I'll let Dr. Sneha.
Reflux is one possibility, but CMPA also, but it comes later on. 7 days is too early. I'll go with reflux first. So the approach would be, frequent regurgitation. Regurgitation is okay, but if it is associated with poor weight gain and then there is feeding intolerance, as in what was happening, ma'am? I would like to understand that better. Was it just vomiting?
More spit-ups, more vomiting, irritable.
Okay. Irritable, okay. Then
not sleeping well, always crying, arching the back.
Then that would be, it will become GERD rather than just reflux. So
yeah, only reflux doesn't usually cause problem. Unless it becomes a problem, then we say it's GERD. We add the D part.
Yeah, I think some of the symptoms of GERD are evidently seen in this baby, such as frequent regurgitation. We may also see the baby refusing to be kept in a lying down position, preferring to be kept erect, frequently arching, frequently spitting up milk, excessive salivation. So these are all excessive irritability, not sleeping well. These are all some symptoms of gastroesophageal reflux, and this baby also is manifesting with poor weight gain and is obviously calling for help. So when it comes to management of gastroesophageal reflux in an exclusively breastfed baby, some things that can be done are to promote small frequent feeding rather than spacing out feeds over long gaps, and then the baby probably going into rapid and excessive feeding during a single feed. So rather than doing that, it might be better to advise the mother to actually split the feeding into small and frequent feeding. Of course, the importance of positioning the baby erect for at least 15 or 20 minutes post the feed cannot be overemphasized. It is very, very important to talk to her about positioning and talk her out of the role of anti-reflux medications and trying to tell her 90% can be managed with just positioning the baby erect. The role of positioning aids like using a car seat or using a special chair may have a special role in some special situations where reflux may be significantly structural, like for example in post-op tracheoesophageal fistula where we anticipate reflux. These may be some babies who may benefit from a special car seat, a propped up position which may need an additional support. For most term babies who are otherwise neurologically normal, it may be still quite manageable by just positioning baby erect on one's own hand or probably on the shoulder. If the mother is on caffeine, it may be important to talk to her to try and restrict the use of caffeinated drinks such as coffee and tea. There may be smokers in the family, so it might be also important to try and find out if the baby is getting exposed to passive smoking. Strict no to smoking. Very important here to not kind of indulge too fast in special formulas or hydrolyzed formulas or avoidance of cow's milk products, because very often we do see prescriptions, we do hear parents coming back and telling that they have been asked to restrict milk protein, the mother has been asked to avoid dairy, or very early the switch to special hydrolyzed formulas is done, and this sadly cuts down exclusive breastfeeding completely. So there are a lot of non-pharmacological interventions that can be successfully undertaken in babies with problematic gastroesophageal reflux disease. The role of pharmacological interventions like domperidone and anti-acid reflux measures such as lansoprazole has been very controversial. Most neonatal literature does not support the use of proton pump inhibitors in neonates because it increases the gastric acid pH and hence may predispose babies to infections. This may be reserved for babies with GERD who may not improve to traditional measures only. It's also important to remember that domperidone comes with its own side effects, including QT prolongation.
I have 3 questions here for you. What is your experience? All 3 I'll say, then you answer. What is your experience with lansoprazole and domperidone? Second thing is a controversy about ranitidine. So what is it right now, the status? And more importantly, American Academy of Pediatrics says we have to put the baby to sleep only on the back and only flat, no inclination, because of the risk of SID, yes, sudden infant death syndrome. So how do we guide these parents?
So ma'am, in our experience, we try not to use any medical measures at all for GER. Even in our preterm babies, I think we hardly ever use acid suppressants. The American Academy of Pediatrics does not endorse the use of lansoprazole or ranitidine at all. Even in an occasional baby where we have to resort to the use of pharmacotherapy, if there is clear-cut history of, say for example, post-feeding DSATs in a preterm baby, which probably is related to gastroesophageal reflux subtle form, we may sometimes use only domperidone, but we definitely try to avoid the use of lansoprazole. In term babies, we have practically hardly ever used either of these medications. So the same thing holds true even with ranitidine. And the third question was the position. So the American Academy of Pediatrics, yes, endorses the baby on the position should always be back to sleep. So what we advise our parents is, do not keep the baby prone or do not start tummy time unless the family is ready to being able to.
My question is about the inclination.
The inclination, the angle.
We used to advise them to keep the baby to sleep at 30 degrees, 20 degrees, but American Academy of Pediatrics clearly says no.
Yeah. So we do not.
Unsupervised, you are not supposed to.
We do not routinely advise inclination or head end elevation, ma'am. I'm sorry, I thought that you are talking about the prone versus supine position. We do not routinely advise head end inclination in sleep. It is extremely difficult and challenging. Most babies do not like to be propped up. Two, it also does not really help. So.
Okay. And actually we thought, we thought we'll wind up with 6 questions, but all the panelists came prepared for 3 questions each. So if any of them want to say anything, I want you all to say, and then we'll wind up. Yeah.
Yeah, so hi, this is Johita, I'm neonatal therapist. So when it came to positioning, I just want to add one thing. We can advise prone on tummy position only when the baby is active and awake.
And supervise.
And supervise under close observation. Yeah. So whenever we are writing, we are telling them, then I would like to mention there under close observation, because that I do so many times and I've seen lots of changes in the babies, and obviously that is main of because their tummy muscles are little weak also. Sometimes you will see such issues. So if we will properly guide such things to the parents, that will be really helpful.
That also helps in preventing positional plagiocephaly.
Yes.
Yeah, but supervised.
But supervised,
every microsecond.
So I say, like, before feeding, you please go for tummy time for, let's say, 5 to 7 minutes, as much as baby can tolerate, because not much baby like the position.
Yeah, baby has to be comfortable.
So that's why, and they can do in any position. They can do on them also. It's not necessary only on the floor or anywhere. And there should be no toys or anything, soft toys, anything around their nose or anything. So that can be followed. It's very easy to advise.
Thank you. Okay, anything?
Yeah, just one point. I think I had referred a similar child to Dr. Aparna about a year back. One of my close friend's wife who delivered, who had a bad reflux. And Lansol doesn't help. There's no point in writing it at all. I did look up some literature. Probiotics apparently have some role. I don't know what the guidelines say. But what works definitely, which the mother will do, is to stop dairy. Once they stop taking milk altogether, somehow it improves. But I concur with what Dr. Aparna says. There's no evidence.
But I think
all literature doesn't show. Yes. So please do not advocate for all this. There are many things that mothers will do which makes something better. That doesn't mean that is science or there is no logic to it. And you cannot explain how it is better. If you replicate it to somebody else, it may not work. So please do not suggest it. What is in the books you suggest, and I agree with what Dr. Aparna says. Somehow the point is avoid caffeine. That definitely is written. For dairy, I don't know where it is written, but somehow it is done.
Here it is too early for cow's milk protein intolerance. Second thing, Nelson's textbook still says that in GERD you can still give antacids. But yeah, I think we should minimize. I will work on it myself. Okay, right? After trying everything, if it doesn't work, we have to solve the problem for the baby. We can't let the baby go on crying and be in pain. So in that case, we should definitely try the other measures. Yeah, I think that's it.
What? So,
KIMS probably helps because of the posture.
Yeah, posture, tummy pain will come down, they feel comfortable, and weight loss is also there. That also helps.
Yeah. So what I ask mothers is, they say ettukunte bauntundi. Then I ask, ila ettukunte bauntuda, ila ettukunte bauntuda. That also we need to check. Because whether they want to be held, that's why they were crying, because they weren't being held, or is it the position that they need? So that also is very important. So history, talking to the mother, spending some time, not like rush, write some, eat this, eat that. Talk to the mother.
The last thing is, in concurrence with all of this, baby wearing. The kangaroo mother care, the baby wearing helps because they can then also feed the baby in the baby wearing position.
Only thing is, you'll have to guide the mothers about the right methods of baby wearing again. You know, mother should be able to look at the baby's nose should not be pressed against the chest. So all these things, frog leg position, everything you need to guide the mother well. Okay.
Aparna ma'am said small feet, I would like to suggest frequent burping in between the feet.
Yeah, in between the feet, burps. So I think you have heard everything, but I am telling you, 95 to 100% is in the here. How you support, you take her through, how you make her believe that she can feed her baby. All this, eat that, all that. I don't agree. And galactococs, as you said, in preterm babies, maybe, but main thing that comes is what you believe, and ensuring people around her have a positive attitude, support her, and understand that first day only 5 ml can come from the breast. I don't expect some milk to be gushing out on first day. So all this they need to understand. They need to understand, be positive, just work on this and heart. Nothing else, all these laddus, kiddus, everything. Then in that case, in the rest of the world, nobody should be breastfeeding their babies. If only Indians are, I'm sorry, but I don't agree with that. It's about how you eat a balanced diet, nutritious diet, talk to the mother, give her confidence, and let her make informed decisions. Remember, every mother does the best for her child. If she is not able to breastfeed for some reason, don't look down upon her and say, you can't even breastfeed or what. That also don't do. Support, try your best. If it doesn't work also, she's the best mom for her baby. Okay, thanks.
We have another mic, please. Come stand here.
In the hospital, a lot of for cleft lip, ma'am, for cleft palate, pigeon feeders are coming. I find them very difficult. The flow is too fast. It's so difficult to control it. Any experience with others? Yeah, they're cheap. So even if we write special feeder, even if someone is affordable, and we write for a special feeder, ultimately that is what they're buying, and it's actually causing problems.
I thank all the faculty as well as the delegates who have stayed back until the end, and I'll be failing in my duty if I do not thank all the faculty who have shown so much of enthusiasm. May I kindly request Dr. Rohini to please felicitate, I think, Dr. Shivaranjani and Dr. Shravanti for the last session. We have actually felicitated all the other faculty in one of the sessions. So I'd like you both to please come on to the stage and we have something as a small token of appreciation. So while we are wrapping up, may I also request Dr. Surendra Rao, who has joined us. He is Secretary of State NNF, Consultant Neonatologist from Rainbow Children's Hospital. Thank you, Dr. Surendra, for joining us. I know it's been a long drive for you. Please join us and you actually can stay here. So just before... So thank you all for joining on Zoom.